Morning, everybody.
Good morning, Dr. Patel. Hello, Dr.
Morning.
Patel. Good morning.
Good morning. Great to have you in a meeting, Dr. Tarjani.
Thank you, Dr. Patel. Can I quickly check if my slides are running? I was unable to share screen earlier.
Yeah, sure. Ehsan, could you please stop sharing that poster so Dr. Tarjani could check? Thank you. So stage is yours, Dr. Tarjani. احسان ما الان تو VIP هستیم یا تو سالن اصلی هستیم؟
Are you able to see the video running, sir, smoothly?
Yeah, that's great.
Right, that's all that I wanted to check. So thank you so much. I'm going to stop sharing now.
Perfect. So how are things, Dr. Tarjani? Are you in operating room?
Yes, I'm in the OR right now, and I'm going to quickly wrap up one case and join you again, but I'll be logged on. Are you able to hear me, sir?
علی جان پوستر رو دوباره بذار.
احسان جان سلام، صدای من داری؟
سلام دکتر، درود بر شما. بله، من صدای شما رو دارم.
ارادتمندم. من یه بار اسلایدمو شیر بکنم.
دکتر جوین بشین توی اون بریکاوت رومی که ساختم که همکار با هم باشین.
کجا هست؟
الان اساینتون کردم.
خب
جوین
چجوری برم اونجا؟
باید جوین کنی، بریکاوت روم جوین کنی.
الان کلمه جوین برای من نیومده، چیکار بکنم؟
چرا اون پایین باید اومده باشی براتون؟
نه اون پایین همین تاپیکایی که تو خود زوم هست. مور پارتیسیپنت شیرز تا ویدیو میوت جوین نیومده.
یه لحظه اجازه بدید.
احسان تو تصویر منو داری؟
بله دکتر، من تصویر شما رو دارم.
خوبه جامینا، خوبه. من خودم ندارم، نمیدونم، یه تستی قبلش با کامera کردم ولی حالا باز نورش
اوکی،
رو
نه اوکی خوبه.
اوکی خب.
من اینجا استاپ میکنم دکتر، همینجا اسلایدتون تست بکنی ببینم مشکل چیه. دکتر فایلتون رو شیر کردین الان؟
من نمیدونم چرا تو دانلوده ولی نمیدونم چرا اینجا خیلی سخت پیداش میکنم. یه لحظه الان صبر.
اوکی.
اینجا میدم سرچ داره، تو واتساپ سرچ رو بزنم پیدا بکنم، بردمش تو واتساپ ولی سرچ هم نداره. برم از اون طرف تو خود اسلایدیام میتونم شیر کنم از اون ور؟
جانم دکتر متوجه نشدم.
عرض کردم برم از تو خود دانلود بیام میتونم شیر بکنم؟
قاعدتا باید بتونین، ولی بهتر اینه که اگر اینو توی گوگل درایوتون دارین از تو گوگل درایوتون شیر بکنین یا
نه تو گوگل
دراپ
درایو ندارم. نه بفرستمش تو گوگل درایو.
بله بله، اگه میتونین این کار بکنین بهتر.
من آوردمش تو زوم، توی چیز آوردمش تو زوم. نمیدونم حالا این کار درستی بود یا نه.
درسته دکتر، بله درست.
خب الان تو زوم چیکارش کنم؟ فقط ویو فایل. الان شیر شده؟
نه دکتر، شیر نشدم. من نمیبینم.
احسان جان صدا من میاد؟
بله دکتر، من صدا شما رو دارم. شیر نشده هنوز
شیر
فایلتون.
شده؟
نه.
میبینیش تو؟
نه من چیزی نمیبینم دکتر.
من آوردمش توی چیز، آوردمش توی این زوم. حالا ببینم میتونم اینجا پیداش کنم. اصلا چطوری میتونم ببرم تو گوگل درایو از اینجا؟
دکتر فایلتون که الان داری میتونی شیرش کنی دیگه، تو شیرتون میتونی تو گوگل درایوتون اساینش کنی.
تو شیر رفتم نداره گوگل درایو.
جیمیلش کنید، توی جیمیل با گوگل درایو بفرستید.
تو اتاق وی آی پی.
دکتر من ایمیلمو برای شما فرستادم، میتونین برای من ایمیل
خب
بکنین فایلتون رو.
خب
اگه 1% شما نشد شیر بکنین، من اینجا براتون شیر کنم، جابجا
دکتر
کنم
پاکر
که
براش فرستادم. پاکر
آها
براش
خب دکتر
فرستادم.
داره.
آره
اوکی بسیار عالی.
آره، فقط به من گفتش که بفرست تو شما منو ببرید تو اون روم وی آی پی همچین چیز.
خب ببین دکتر یه دونه الان من اونجا توی قسمت مور باید داشته باشی که بتونین جوین بشین توی بریکاوت رومتون.
مور ارزم به حضور شما که
پایین سمت راست روم یک همچین چیزی باید داشته باشی.
نه والا چیزی ندارم اینجا. این پایین استا ویدیو داره، میوت داره، شیر داره، پارتیسیپنت داره، مور. آها مور دید. خب چیکار بکنم؟ برم تو این چیکار
روم
بکنم؟
یک بریکاوت روم یک.
چت یک زده.
نه روم یک. رفت.
روم یک نداره اینجا اسا.
چی دارین دکتر؟
raise hand, record, disconnect audio, security, chat, meeting setting.
داره. همه دارم بر نباید اینجوری باشه. اجازه بدید.
میخوای از همینجا من اضافه میشم؟ اگه مشکلی هست از همینجا نمیدونم میشه اصلا یا نه.
باید از همینجا اضافه بشین دکتر دیگه.
عیبی نداره. من چیزی برای جوین و اینا برام نیومده، نمیدونم حالا چه جوریه سیستمش.
یک بار خارج میشین دکتر، دوباره وارد بشین. یه لحظه
بله
بدید، فکر کنم دارم برمیگردم گوش. جانم دکتر. قربان شما. بله. نه ببندم رومو. های. دکتر صالحی اومده ولی نمیتونه جوین بشه تو اون بریکاوت روممون. نمیدونم مشکل چیه.
میخوای من میرم دوباره میام؟
دکتر صالحی
بله.
باشین، فکر میکنم الان برمیگردن همین.
من پس بیرون نرم.
Morning, dear colleagues. It's a pleasure for us to start the mucormycosis webinar today. So we are very happy to host lots of stars in the COVID and mucormycosis. So as you know, we had a rise in the incidence and severity of mucormycosis cases in the last couple of months. So we had to struggle with this deadly disease, and many countries were involved with this deadly disease. So now we have international collection of experts in this field and start this meeting to actually inform and update and possibly could help our patients. My co-directors, Dr. Salehi and Dr. Ashok Grover. Dr. Salehi.
Can you hear me?
Yeah, perfect.
Dear Professor, thank you for your efforts, and I'm great to participate in this scientific meeting, and welcome to my colleagues and our audience. And I hope we could hold prestigious and scientific and useful meeting for our audience.
Thank you very much. Professor Ashok.
Thank you, Professor Prasad. It's a privilege to be a part of this meeting and to be a participant in this subject, which is of so much public health importance, particularly the ophthalmologists and the rhinologists and the internists as well. I think the crisis has struck us very hard and in a very quick fashion, so that we were found relatively unprepared for it. A webinar like this will make sure that we are ready to face this crisis better as a multidisciplinary team in our hospitals. To put things in perspective, we had reported 25 cases of mucormycosis before the COVID era over the previous 4 years. Then in the first wave, we got 31 cases during the first 6 months. And in the second wave, we have admitted 189 patients and seen many more within the last 3 to 4 months. So this is the magnitude of the crisis, and India reported over 46,000 cases countrywide, with resulting difficulties in managing patients, including finding enough drugs. So I think it's a wonderful initiative from Fazad to have brought this to the fore, so that all the other countries, particularly the developing countries, are better prepared to face up to any crisis coming up in this or future waves. Thank you, Fazad. Looking forward.
Thank you very much. Thank you very much. So we will start with the section 1. In section 1, we have quick lectures, and we will overview the mucormycosis and updates on that. Then we'll go to Q&A. So dear colleagues, you may kindly put your comments and questions in the chat box or raise your hand at the end of the section 1. After section 1, we'll start section 2. It's very, very interesting. It's a grand run with experts. We'll review interesting cases and go deep inside the mucormycosis. So we'll go for the first speaker, Professor Mohammad Reza Salehi. Professor Salehi is a faculty member of Tehran University of Medical Sciences in Iran. He's the infectious disease specialist, especially in COVID-19 and mucormycosis. Dr. Salehi, the stage is yours.
Thank you, Professor. And unfortunately, Professor, I cannot share my slide. And if it's possible for you, you get the slide me, and I start.
Ehsan, can you show slides, please? Thank you.
Thank you. First of all, I would like to have many thanks from Professor Paktel for holding this webinar. And after that, this is Dr. Saleh from Iran. I'm infectious specialist. Today, I want to talk a bit about mucormycosis in patients with COVID-19, how to approach. Next, Issa. Thank you. Uh, as you know, SARS-CoV-2 is a member of the family Coronaviridae that's responsible for COVID-19, previously known as 2019 novel coronavirus. Next. This virus could cause the latest pandemic in human communities. We are currently in the second year of the COVID-19 pandemic, and the main concern of all countries right now is the provision of COVID-19 vaccine and the concern about new variants. Thank you, Essa. Mucormycosis is a serious but relatively rare fungal infection caused by a group of mold called Mucormycetes. These molds live throughout the environment. Inhalation is the major route of occurring mucormycosis. It most commonly affects the sinuses or the lung after inhaling fungal spores. This infection tends to occur most often in immunocompromised hosts. Next, Essa. It was almost the beginning of COVID-19 epidemic that some experts in the field of COVID-19 noticed an increase in the number of fungal and bacterial co-infection, while most of the patients had history of severe COVID-19. Next, Essa. The expert believed that the widespread use of systemic glucocorticoids and tocilizumab as the treatment of COVID-19 could lead to secondary bacterial or fungal infection in these patients. Thank you, Essa. Pulmonary aspergillosis as the first or second fungal infection complicating the course of COVID-19 was widely recognized in many studies, but mucormycosis is uncommonly suspected or diagnosed by the end of 2020. Thank you, Essa. Reports are increasing on the emergence of COVID-19 associated mucormycosis CAM globally, driven particularly by low and middle income countries. The recent unprecedented surge of CAM in India has drawn worldwide attention. More than 28,000 mucormycosis cases are counted in India. Next, Essa. This article is the first article that you see the first case of COVID-19 mucormycosis co-infection. In this post-mortem study, the investigator report the patient in 22 years old with lung involvement with mucormycosis. This patient involved with severe COVID-19, and in post-mortem evaluation, as you can see in a picture in the right, lung tissue involved with mucormycosis, and you can see black scar and necrosis. Next, Essa. I think this is probably the first report from India from the as a case report with Rhino-Orbital-Mucormycosis associated with COVID-19. As you can see, this patient involved with severe COVID-19 in the right side picture, you can see lung chest CT scan with ground glass opacity in both lung, and in the left picture, you can see coronal paranasal CT scan and orbital CT scan with involvement with mucormycosis in right maxillary sinuses and right orbit. Next slide. Mucormycosis in patients with COVID-19, a cross-sectional descriptive multicenter study from Iran. Next slide. In this study conducted by Professor Pakdel and our colleagues, a cross-sectional descriptive study on biopsy-proven mucormycosis patient with laboratory confirmed COVID-19 from April to September 2020. Next. 15 patients with laboratory confirmed COVID-19 and mucormycosis were included in this study. Median age of patient was 52 years old and 66% were male. 8 of 15 patients, 53%, had diffuse lung involvement as a severe COVID-19. Next, Esther. The median interval time is so important for clinicians. Between the onset of COVID-19 and the first symptoms of mucormycosis was 7 days. All patients had underlying diseases. More common underlying diseases was diabetic mellitus with 87% of patients. 7 patients had received intravenous corticosteroid, either dexamethasone or prednisolone for treatment COVID-19. Next slide. All of the patients were treated with intravenous liposomal amphotericin B. 3 patients, 20%, took additional fluconazole and caspofungin as a triple therapy and as salvage treatment. All of 3 patients could save by clinicians, and the result of this treatment was antifungal combination therapy was significantly associated with better outcome. 7 patients unfortunately succumbed as the result of mucormycosis. Next. This is a preprint that published with the Lancet, the emergence of COVID-19 associated mucormycosis analysis of case from 18 countries. Next. This study is a review from the case report from 18 countries during March and April 2020. Most of them are SARS-CoV-2 and proven and probable mucormycosis. Next. They identify 18 cases with CAM. Cases were reported from 18 countries, the majority from India, 42, United States, 8, Pakistan, 5, and France, 4 cases. Next. Diabetes, as our study, was the most, was the most prevalent condition overall. And diabetes was even more predominant as a risk factor in cases reported from India, 95.2%. Next. Treatment with systemic corticosteroid was reported in 72% of cases, although tocilizumab was administered to 6 patients in addition to corticosteroid. Next. Mucormycosis was diagnosed to median of 10 days after diagnosis of COVID-19. 24 patients, 30%, required advanced critical care for at least 1 day prior to onset of mucormycosis. All cases mortality was 48.8%. Next. Ehsan, please, next. And that is the last article I present in this presentation, and it's so interesting to me. ISHAM recommendation for clinical management of COVID-19 associated mucormycosis in low and middle income countries. Next. Early warning signs of ROCM, Rhino-Orbital-Cerebral Mucormycosis, facial pain, nasal blockade or congestion, bloody brown black discharge with or without local tenderness or pain. Furthermore, patient may develop facial numbness or edema during involvement of maxillary, frontal, or ethmoidal paranasal sinuses. Next. Recommendation from Isham in the first early suspicion and confirmation of diagnosis. Standard management include glycemic control, elimination of corticosteroid therapy or at least tapering of corticosteroid therapy, extensive surgical debridement, and antifungal treatment. Next. Imaging. Most of our patients need at least prenasal sinuses computed tomography, and based on their symptoms may need brain and orbital MRI. Next. Mycological diagnosis. A definitive diagnosis can be made by microbiological and or histopathological examination of tissue obtained from different lesions. And next. Treatment approach. Invasive mucormycosis is a surgical medical emergency condition, and frontline antifungal therapy with liposomal amphotericin B should be initiated at the earliest. The team generally consists at infectious disease specialists, mycologists, ENT surgeon, ophthalmologists, histopathologists, and pharmacologists. And next. Thank you for your attention. This is an event in Imam Khomeini Hospital complex before of COVID-19 pandemic. I think we missed this day. Thank you so much, Professor.
Thank you, Dr. Salehi, for the great presentation. Very informative. So,
thank you.
Professor Ashok, you may kindly introduce the next speaker. That's me.
Privileged to introduce Dr. Farzad. Dr. Farzad Pegdil is a professor at the Department of Ophthalmic Plastic and Reconstructive Surgery and Vice Chair of Education Department of the OPRS at the Farabi Hospital in Tehran University of Medical Sciences. But this is just one of his activities. He's also editing several prestigious publications and journals. He's also heading a number of virtual teams and research associations in Iran and elsewhere. He's a board member of International Thyroid Eye Disease Society, a prestigious position, and he's a board member and counselor for the Asia Pacific Society of Oculoplastic and Reconstructive Surgery. Most of all, he's a man with great initiative, great foresight, and his range of publications is really mind-boggling. And active researcher, great friend. Looking forward to listen to him on this important subject of what we have learned in the COVID-19 era on orbital mucormycosis. Welcome, Farzad.
Thank you very much for your kind introduction. So in the next 10 minutes, I will cover up a few important points about the mucormycosis associated with COVID-19. So I have no conflict of interest. So we know that this is a fungal, life-threatening condition that usually happens in immunocompromised adults. And after starting the pandemic of COVID-19, like in March, we observed that there is a rising number of cases with mucormycosis. That raised an idea that may be association between the COVID-19 and mucormycosis. That was the subject of that study that Dr. Salehi mentioned. And interestingly, after each wave, after each surge in incidence of COVID-19, we are seeing an increasing number of patients with mucormycosis. And there is a recent report from India showing that it's almost twofold rise in mucormycosis compared to the pre-COVID-19 era. Also, the invasiveness of this condition sounds to be greater than before. As a whole, 49% of patients with a mucormycosis associated with COVID-19 succumbed from the disease. And from those that survived, about half was blind. So what is truly the association with COVID-19, the viral disease, and mucormycosis, the commensal fungus? And it's because in COVID-19, we may experience respiratory distress. The patient may get IC admission, undergo mechanical ventilation. The patient may receive high-dose corticosteroids, immunomodulators. Very interestingly, when we have COVID-19, we may have some local inflammation in the epithelium of the respiratory tract, and we have cytokine release around the epithelium, and oxygen burst and oxygen released in that area may break down the epithelium and predispose to actually invasion of the different kinds of fungus. Also, in these patients, we may give broad spectrum antibiotics, and more importantly, lots of COVID-19 patients have underlying diseases, especially hypertension and diabetes mellitus. Even worse, during admission, during actual acquisition of COVID-19, there is exaggeration of the immunosuppression. Also, the iron that's essential for growth of this fungus is released. So all of these may explain why there is increased incidence in the mucormycosis associated with COVID-19. So it's very important to remind that the diagnosis is not straightforward. It's always a challenging situation because we have no specific clinical or radiological signs. We need a constellation of everything, clinical and radiological, and finally biopsy to prove that this is a case with invasive mucormycosis. So let's review and compare to actually pre-COVID era. So we found in our studies, and also in comparable, it was comparable to other studies, that the most important comorbid predisposing factor among these patients is diabetes mellitus in about 86%, and then hypertension 46%. Almost all of them received kind of immunomodulation, especially IV corticosteroids. So this is one of our cases, one of our initial cases, a 7-year-old woman that experienced visual loss 4 hours before coming to emergency theater in Farley Hospital. So she explained that she was experiencing mild facial and orbital pain for like 5 days, and she had diabetes mellitus for 2 years. And interestingly, she denied any respiratory problems, respiratory symptoms, and fever. The patient was NLP in right side and total external and internal ophthalmoplegia and ophthalmic artery occlusion. So examining the heart palate showed necrotic black scar called a SHAR. So it was probably a case with mucormycosis. So let's review the signs and symptoms of these patients. This is a long list. You may see different kinds of symptoms and signs in these patients, but one very important thing, 73% of these patients presented with orbital apex syndrome. It shows that the timely diagnosis needs careful examination, especially by ophthalmologists, to pick up these cases before some disaster happens for these patients. Let's have a look on bacterial and fungal infection, bacterial and fungal cellulitis. In the left, we are seeing a gentleman with acute pain, swelling, external ophthalmoplegia, and he was experiencing lots of pain and lots of erythema there. But look at the lady with mucormycosis. We have, again, external ophthalmoplegia, but we haven't that much swelling. We haven't any pain. But the patient is blind. So the exterior of this disease sounds quiet, but inside there is kind of very, very actually critical signs. So for any case suspicious to mucormycosis, we'll start with imaging. CT and especially MRI is essential for all of these cases. Let's have a quick look here. Usually after GAD injection, we have no enhancement or just minimal enhancement. Usually the enhancement is heterogeneous, but it may be homogeneous in these patients. But look at here, we have a heterogeneous enhancement, swelling or engorgement of the medial rectus muscle here. We have a minimal amount of the ethmoid sinus swelling here. And the most important thing here that guided us was the restriction in the restriction pattern in diffusion weighted imaging and ADC map, showing that we have infarction of the we have infarction of the right optic nerve. And look at here, we have actually restricted diffusion. It shows that we have kind of occlusive phenomenon here. So we checked the patient with chest CT scan and found out this typical pattern. After checking the PCR, found that the patient had concomitant COVID-19. The pattern involvement of sinuses compared to the known COVID associated patients. Look at here, we are seeing that about 90% of patients with CAM are experiencing orbital involvement compared to 76 with known CAM. Look at here, brain involvement, about half of cases in CAM, but just 12% of cases in non CAM. Again, deep skull base and PPF involvement are much higher compared to pre-COVID era. It signifies that the more invasive nature of this disease comes from the involvement, rapid involvement of these vital structures. Biopsy is the gold standard for diagnosis. It's essential to know that we should take multiple biopsies, not just one biopsy. And if we miss to diagnose with one biopsy and still we are suspicious, we should go for another biopsies. The drawback of the conventional biopsy is that it may be time consuming. So we are searching for a test that could be reliably diagnose the patient condition. So we can go for semi-nested PCR. That's a new kind of this PCR that needs to be verified. And again, there is another good technique with intra-op frozen sections. Both of these actually modalities of diagnosis have a good predictive value above 90%. So what do we see? We are seeing non-septate, broad, actually hypha inside the tissue, and we can see angioinvasion and tissue necrosis. So this is the pattern that's pathognomonic for mucormycosis. Some others actually try to classify the Rhino-Orbital-Cerebral Mucormycosis in terms of formulating treatment. When the disease starts from the nose and paranasal sinuses, then involve the orbit, then intracranial extension, it goes from stage 1 to 3. And look at here, unfortunately, the frequency of stage 3, that's the more advanced, is higher than the other one. And okay, look at here, we have very informative data here. We showed that the median interval time between COVID-19 and mucormycosis in CAM is 7 days, with a range of 1 to 37 days. What's the significance? It shows that even when the patient is admitted or under observation for COVID-19 may experience mucormycosis. So the physicians and the health care providers should be careful about picking up any actually pathologic findings in the clinical examinations. So very quickly, the treatment should be very quick and aggressive. if we are suspicious to mucormycosis, we do not stop for receiving the pathology actually confirmation. We start antifungal, systemic antifungals. We have at least 2 broad actual spectrum of antifungals, polyens like amphotericin. We have 4 families of amphotericin, and we have now triazoles like prosaconazole and isavuconazole. Both are available now. And also we can use as like combined or salvage therapy for these patients. Another very, very attractive modality of treatment that we observe, sometimes it's just saving the eye and saving maybe the life, is the intraorbital injection of amphotericin that Professor Reza Baghefi will educate us about that thing. And we should remember that when we have some necrotic tissue, we should aggressively remove any necrotic tissue. It's very essential. As soon as we have some tissue that's necrotic left behind, there is a nest for progression of disease. So there's always a question when we should go for exentration. I will talk a bit about that, and we have other options like hyperbaric oxygen therapy and GCSF for those with actually lymphopenia or thrombocyte or leukopenia. So another interesting thing is that the fungus can enter the orbit not just through the paranasal sinuses. And look at here, I may show you another interesting case. Just recently, we observed a patient with medial orbital necrosis. And when we went there for debridement, taking biopsy, we observed that the medial wall of the lacrimal sac is totally necrotic. And when I opened that necrotic tissue of the lacrimal sac, some pus drained. And very interestingly, the patient didn't show any warmth, any erythema or something, just kind of swelling over there. And from this same actually entry, we drained the orbit. Sorry, I missed my PowerPoint. So for sake of time, we'll be more. So decision for exentration is always a critical one. And there is no clear-cut definition or indication for doing exentration in patients with mucormycosis. Further, there is a controversy in the literature. We have Dr. Hargrove in 2008 that showed patients that underwent exentration had a better survival. Dr. Kashguli and colleagues in 2019 showed there is no change in survival rates in those that were exentrated. So there is contradictory results in the literature. We can give no definite answer if it really works or not, and when we should go for exentration. But I can say that we have some clues that will help to decide when should we go for exentration. We should consider vision, the salvageability of the orbit. Can the orbit be salvaged? What's the extent of necrosis? Where is the necrotic tissue inside the orbit? How the disease progress? Is it a fulminant one? Is it threatening the life, or just going like every week a bit progression? And what's the patient's perspective? Sometimes the patient says, by no mean I will let you to remove my eye. So these are the factors that should be considered. So in conclusion, the association with COVID-19 and mucormycosis is a fact. The poor control of diabetes mellitus is an important predisposing factor that should be addressed very seriously among the patients with COVID-19. Almost half of patients with CAM have an advanced stage of the disease at presentation. It shows that the treatment team should be very aggressive and very quick when we face with a patient with CAM. The medial interval time, once again, the median time is 7 days, and the range is 1 to 37 days. The combined antifungal therapy may be associated with the higher survival rates. We observe that we have a better survival in patients that receive salvage therapy compared to those that just receive intravenous amphotericin. Clinicians and patients should be notified about this association and alarming signs, we say, for the first 5 weeks after the COVID-19. Thank you very much for your attention.
Thank you, Farzad. That was an excellent presentation. It not just highlighted your data, but the conclusions that were drawn from the data were really impressive. First of all, this association with diabetes is important, very important, even in India, where over 90% of the patients have had known diabetes, or very importantly, many more who were hyperglycemics at the time of presentation. So the possibility of COVID-inducing hyperglycemia, or the steroids that are being given at the same time inducing hyperglycemia, and inadequate hyperglycemic control is possibly one of the most important factors. Your indications for exenteration were very well outlined. We need to be working on that, and we are analyzing our data, our survival rates, our exenteration rates, and we hope that with our about 200 cases, we may be able to come up with some recommendations based on what conclusions we have. But we look forward to much more data from around the world, some excellent data we have from Iran as well. Thank you.
Thank you, Ashraf. So I would like to invite Professor Reza Vagheffi. Professor Reza Vagheffi is a professor of ophthalmology, oculofacial surgeon in San Francisco University, and he has actually a deep knowledge and experience and studies in mucormycosis. We are honored to have Reza here. Reza, the stage is yours.
Thank you, Farzad. And I want to thank you for having me and for this opportunity to be a part of such a group. And it's great that we could have this conversation, discourse. And I've already been learning quite a bit, because our experience is a little bit different in the United States. And as far as the incidence that you see, these two diseases in tandem presentation, we haven't seen quite the extent of that here. Let me share my screen. So I was going to speak about a modified treatment ladder algorithm using retrobulbar amphotericin B for invasive rhino-orbital sinusitis. Now, this study that I will present at the latter half of my talk was performed prior to the pandemic. So it does not include any COVID-19 patients, but it does provide a perspective of a potential treatment option. So Dr. Pakhtel nicely covered this already. We're all familiar with this. It's really a three-pronged approach that must be followed in the treatment of this disease. And that begins with starting the systemic antifungals. Here at my institution for mucormycosis, amphotericin B is our first line. For aspergillus, voriconazole is our go-to. And of course, when possible, and often this is a more difficult task at hand, we need to reverse the immune status when possible. At my institution, we have those that do present in diabetic ketoacidosis that represent a good number of these patients, almost 50%. But then the other group, proportion of patients are those that have hematologic or oncologic malignancy, and with a smaller number of patients that are immunocompromised because of organ transplantation. And so we see another 50% that come from this other patient group at my institution. And of course, we have already mentioned the surgical debridement, including the endoscopic debridement, and I'm going to focus on treatment of the orbit. And as Dr. Pakdel alluded to earlier, really the existential moment for the oculofacial plastic surgeon is whether they're going to exonerate this orbit. And we struggled with this at UCSF, and we looked at the literature, and then we really wondered how we were doing as an institution. And so we decided to do a retrospective study reviewing our cases. And just like the Kashkuli study that was published in 2019, we were also published the same year. And our cohort, our design was a retrospective review, and our cohort had 55 patients in it. And our exoneration rate was about 16%. And in our conclusion, we actually, with very stringent statistical analysis, we did not find that orbital exoneration confirmed any additional survival benefit. And it was really prompt sinus debridement that portended to a decreased chance of death and better visual acuity outcomes. And so just as Dr. Pakdel mentioned this study earlier from Iran, they also found they had a similar finding that exoneration provided no survival benefit. There is a large meta-analysis too performed by Turner and colleagues in 2013 that reviewed over 800 cases. And once again, they also did show that exoneration did not provide an additional survival benefit. And so we really turned at our institution at looking at focusing and pursuing more in the way of local therapy to address the orbital disease. And so we have mentioned amphotericin B. Remember, this binds to the ergosterol in the fungal cell membrane, basically pokes holes into it so that there's leakage of monovalent ions and eventual cell death. Now, prior to 2017, there had been a couple of case reports showing that you could successfully treat aspergillus with retrobulbar injections of amphotericin B. But this was this first case report where we were able to show that you can actually treat mucormycosis this way. This patient presented to our hospital. He's a bilateral lung transplant recipient, immunocompromised for his organs, and he presented with this rhino-orbital sinusitis that indeed came back mucormycosis. Had he presented prior to the time that we instituted retrobulbar amphotericin, we would have exonerated this orbit on the right side. But instead, we initiated retrobulbar amphotericin, and were able to not only preserve the orbital tissues, but actually preserve his visual function, and miraculously ended up with a vision of 20/20 with this scan that you can see 5 months out. And so what is our protocol here? Well, we're using liposomal amphotericin B for our injections just because it is less inflammatory, although these injections are quite caustic to the orbit. They do have to be, the drug has to be reconstituted with water, and water, as everyone knows, can cause almost immediate cell lysis when it's injected into the soft tissues. And so we first perform a retrobulbar anesthetic injection, and then the patient receives the injection of amphotericin, and that's directed in the area of concern, typically along the floor medial wall of the orbit. And we perform these injections daily for 3 days, and then reassess. And if another series of injections need to be performed, then we do it again. And so what is our treatment algorithm at UCSF? Well, we follow these patients very closely with imaging. The intake imaging we know is very important and prognostic to the patient's outcome. So we categorize stage 1 disease, mild disease, as subtle enhancement adjacent to the affected sinus. In these patients, the orbital exam may be normal, and if it's normal, we choose to watch these patients closely. These patients are examined twice a day. Should the exam demonstrate any cranial neuropathies, then we do not hesitate to offer retrobulbar amphotericin injections and to initiate those. For stage 2 disease, this is moderate disease where there's diffuse or apical enhancement. The exam may be normal or abnormal, and once again, we offer retrobulbar amphotericin. In stage 3 disease, this is where we start to transition from the inflammatory stages of the disease to the vaso-occlusive stages, and there's local tissue ischemia and necrosis, and as a result, loss of contrast enhancement on the MRI. And so if this loss of contrast enhancement is small to moderate in areas that are easily surgically accessible and ideally extraconal, and once again, in these cases, the exam's almost likely abnormal, we will perform conservative debridement and institute retrobulbar amphotericin and/or intraoperative irrigation of amphotericin. In stage 4 disease, this is when we have severe disease with loss of contrast enhancement of the apex or over a diffuse area, and the exam's almost always abnormal. And this is really when we consider exoneration, and that's not because we're going to, we feel that this is not going to save the patient's life, but it's because that there is such a infectious burden within the skull base that it should probably be addressed. Of course, just like Dr. Pakdel mentioned, this is a long discussion. Usually the patient's intubated and not able to participate in the discussion, and it's a family member that's trying to help make these decisions. And so I wanted to share with you our modified treatment ladder algorithm study that we recently completed. It was just published in the American Journal of Ophthalmology. It was a retrospective review from 1999 to 2020 of our patients. Basically, what we chose to do was compare patients that were in the pre-era of transcutaneous retrobulbar amphotericin to those that were in the post-era where they did receive the retrobulbar amphotericin. And as you can see, we come just right up to 2020, and we miss the COVID pandemic here. So it does not include any of those patients. And while this is a busy table, the point of it is that, once again, our dividing time point is 2015. Patients before 2015 did not receive retrobulbar amphotericin. There was 20 in that group. And then patients after from 2015 onward received it, and there was 30 patients in that group. And when you compare the two groups, there's really no statistical differences in the demographics. And so just some big findings, and I'll invite you to read the article that just got published. The presenting visual acuities in the two groups were not statistically different. So there were similar groups. However, the final visual acuity was found to be statistically significantly different, favoring the patients that received retrobulbar amphotericin. Now, when we looked at the, and this is not surprising really, at the rate of exoneration, those in the pre-treatment group had a greater risk for receiving exoneration as a therapeutic option versus those in the post-2015 era where they received retrobulbar amphotericin. So more exonerations before 2015. But fortunately, what we were able to show was there was no difference in mortality. By instituting retrobulbar amphotericin, we did not increase the patient's chance of death. And in fact, we were more likely to preserve and salvage the orbital tissue. So in conclusion, one of the things that we did find, regardless of which treatment pre-2015 versus post-2015 when they were receiving retrobulbar amphotericin, if you presented with no light perception vision, that was a grave visual prognosis, regardless of the therapeutic paradigm. And then compared to historical controls, the addition of transcutaneous retrobulbar amphotericin to the treatment algorithm for invasive fungal rhino-orbital sinusitis was associated with increased globe survival, and there was no increased risk of mortality in the post retrobulbar amphotericin era. So with that, I wouldn't be able to stand here or sit here and present without acknowledging all the different collaborators that I work with at our university, and just to showcase our new eye institute. We just moved into this building in 2020, November 2020, right during the middle of the pandemic. And it opened without much fanfare, but if you're in San Francisco, we'd welcome you to come visit and spend some time with us. So thank you very much, and I appreciate the opportunity to speak to everyone.
Thank you very much, Reza. Great presentation and very informative. I would like to invite our colleagues to type the questions inside the chat box, and we will address those questions at the end of the section 1. So actually, that study opened a new way to treatment of the mucormycosis inside the orbit. And Reza, do you recommend the superior part of the orbit to be injected in terms that we have localized involvement over there?
So yes, we do direct the amphotericin in the area of involvement. So if there is involvement creeping up the medial wall towards the roof, it certainly can be injected there.
Mm-hmm. Mm-hmm. Thank you,
Professor. Professor Reza, that was a wonderful study. And our experience during this pandemic, where we handle about 190 patients in our hospital, has been quite similar. We are yet to get a complete analysis of the data, but we used retrobulbar injections in 41 cases, and almost all of them were salvaged in terms of globe salvage, at least. And we've been able to preserve vision by local debridement or retrobulbar injections in a very significant number of patients. So that's a very, very good observation and very good results that will have a lot of impact on how we manage these cases.
That's wonderful news, and good to hear that you've had a similar experience. And please publish that data to support it, to support this this modality.
Yeah. And also, Reza, I would like to share my own experience and my team. We have the same thing as Ashok mentioned. We are seeing a great actually effect of the injection inside the orbit. And apart from one case that we lost because that patient had pancytopenia and unfortunately he succumbed, other patients survived, and we could preserve all of the orbits in those cases. And the other thing I wanted to make a suggestion is that many of these patients have hypoesthesia in V2, V1 maybe. So maybe retrobulbar anesthesia is not necessary for those cases. So I checked the pain of my patient, and if the patient is not has diminished corneal sensation and V2 is diminished, I do not inject any xylocaine there.
That's a very good point. And so often do we see trigeminal involvement. So the other thing I was going to mention was I feel that this is kind of that as oculoplastic surgeons, we've arrived to this moment where our ocular oncologists were at with retinoblastoma, where they were trying to salvage the globe and they came up with intraarterial chemotherapy to do that. And here we're in a similar situation where we're trying to preserve our patient, the aesthetics and the ability for that patient, hopefully to one day to socially reintegrate into society, and ideally without an exonerated socket where they are quite could be quite disfigured.
And the philosophy is great, Reza, because we know that we have that involvement in some parts because this fungus is angio-invasive. We have tissue necrosis or severe ischemia. So when you inject antifungal agents to the peripheral venous channels, the drug cannot reach enough to a reasonable MIC to the region that it needs to be acted. But when you inject directly over that area, you will bypass all of those ischemic and necrotic tissues. So that's a great idea. So we would like to go to the next speaker. That's Professor Azim Tabari. Dr. Tabari is a professor of ENT and Rhinology in Tehran University of Medical Sciences in Imam Hospital. She has a great experience with mucormycosis patients, and I would like to invite her to share the screen. Dr. Tabari, stage is yours.
Thank you very much, and I want to thank you for having me here. I just want to, as you mentioned, I'm Azim Tabari from TUMS, and I'm rhinologist. I'm going to speak about the rhinology perspective on mucormycosis. As my dear colleagues have covered it very well in the previous sessions, I just want to focus my speaking and talk to a rhinology perspective. Rhinology, Rhino-Cerebral Mucormycosis, as you know, is a rapidly fatal disease.
Sorry, Dr. Tabari, we cannot see your slides. Can you please make sure that you have shared your screen with us?
Yeah, sure. I want to share my screen. Is it sharing this screen with you?
Yeah, perfect. So you may go to the first slide because we missed your first, maybe.
Yes, I will.
You are seeing the third one. No problem, no problem.
You're welcome. I'm going to speak about the rhinology perspective on mucormycosis, as my dear colleagues covered previously full, and I won't just go to the point. As you know, that rhinocerebral mucormycosis is a rapidly fatal disease. And to speak about the presentations, patients may, as the new pandemic, COVID-19 pandemic, these 2 years, we have seen a surge in mucormycosis patients when they come to us 7 days, about 5 to 7 days after their recovery from hospitalization and taking corticosteroid therapy. The presentations includes headache, sometimes facial pain and swelling, paresthesia, and or facial nerve paralysis. Paranasal signs includes thick, dark nasal discharge or black necrotic areas in the turbinates and nasal septum. Necrosis of the palate sometimes happens, and ocular signs includes pain, proptosis, ptosis, chemosis, periorbital edema, visual loss, and ophthalmoplegia, as you can see in this patient. CNS involvement includes coma and hemiplegia, and these signs are usually unilateral. Diagnostic clues includes clinical signs and symptoms. As you can see in this picture of our movie, this is the crossing and black necrosis of the middle turbinate and septum. Diagnostic nasal endoscopy will show us the necrosis of the nasal cavity. Contrast enhanced CT scan and or MRI will be helpful, although it might be non-specific, and nasal mucosal biopsy through this diagnostic endoscopy for a culture and prove the diagnosis with histopathology. I want to show you that in CT or MRI, we can find some non-specific changes, but there are some things that in rhino-cerebral mucormycosis we have to focus more, and we should have more attention. For example, in this axial T1 enhanced MRI of the patient of the paranasal sinuses, you can see there is a necrotic scar in the tracheopalatine fossa, and it is the place where the necrosis happens. In this axial CT scan, you can see the asymmetry in tracheopalatine fossa in compared to sides of the patient, and there is necrosis, and there is not any normal fat of the infratemporal fossa that you can see on the left side. On the right side, there is infiltration of that, and there is subtle erosion of the posterior nasal wall, and there are some secretions in the maxillary sinus. This is the CT scan of one of my patients. You can see there is premaxillary infiltration of the soft tissue, which is the normal fat is replaced with necrosis. There is involvement of the maxillary sinus. There's subtle change in the erosion of the posterior nasal wall, and there you can see that even in this CT scan, which doesn't have any enhancement, doesn't have any contrast, you can see that there is not the normal fat of the, when comparing to the normal side, there is not normal fat of the infratemporal fossa, which is liquefied and infiltrated by the necrosis. ENT surgeons are the front line of surgical interventions in patients with mucormycosis. What is our surgical treatment protocol? We usually debride patients. Debridement includes endoscopic turbinectomy, ethmoidectomy, sphenoidectomy, medial or radical maxillectomy. And in rhino-cerebral mucormycosis, as our protocol, we almost always dissect and debride the tracheopalatine fossa and the necrotic parts of the infratemporal fossa. It may be accompanied, may or may not, with cheek soft tissue debridement through the Denker approach, endoscopic orbital decompression or orbital exentration. Very limited debridement might be included in our endoscopic protocol, and palatal resection if there is any obvious necrosis of the palate. Previously, we found that the survival of patients with CNS involvement, especially loss of consciousness, will not change with surgical debridement, because especially because they have some issues when the anesthesiologist wants to accept them in the operating room. But according to recent investigations, surgery is not contraindicated in patients with CNS involvement, including PNS surgery or orbital debridement and exentration, because it will improve their survival. What encounter during debridement includes grayish avascular fungi or like necrosis, replacing the normal yellowish adipose tissue. We may see thrombosis of the terminal branches of the internal maxillary artery, involvement of the infraorbital nerve, involvement of the maxillary nerve after the foramen rotundum and median nerve, involvement of the tracheopalatine fossa and extension into the infraorbital fissure. As we see, because of the thrombosis of the internal maxillary artery, blood loss is very minimal. Our surgical protocol. In our surgical protocol, we are following our senior professor and my mentor, Dr. Sadr Hosseini, who published his article about the pathways of spread of rhino-cerebral mucormycosis in 2005, which has been cited more than 130 times since now. He believed that the PPF conduit is a very important place and reservoir for the mucormycosis to spread to the orbital apex and cranial fossa. PPF conduit has several orifices to the several spaces, like through the infraorbital fissure to the orbital apex, or through the trigomaxillary fissure to the infratemporal fossa and masticator space, through the sphenopalatine foramen to the nasal cavity and foramen rotundum, and trigwig canal to the middle cranial fossa, and through the greater palatine canal to the palate. PPF debridement in rhinocerebral mucormycosis is one of the main issues of concern in our debridement. We use debridement especially in resistant cases, and we believe that it will prevent disease extension to the brain. Debridement of this fossa, which we believe is the major reservoir for the mucormycosis, may effectively seal off the gap of the spread of the disease and positively impact management of and survival of patients with advanced rhinocerebral mucormycosis. Especially, it's important for patients with ocular signs when during the diagnostic endoscopy, we do not find any obvious necrosis or involvement of the nasal mucosa. And their PNS-CT scan may seem to be normal, except their fat stranding in the infratemporal fossa and PPF. And in these patients, we have seen many times that there is a delay in diagnosis. We have to be careful about the trigopalatine fossa. And we usually continue the debridement until the bleeding of other normal tissue occurs. Palatine bone involvement occurs during the thrombosis of the descending palatine artery, and we usually resect limited bone palate, or we resect all of the palatine bone during the radical maxillectomy. CNS involvement happens because of the cavernous sinus involvement, and usually CNS involvement happens because of the orbital apex involvement. Extension from the sinus, sphenoid sinus, and cribriform plate may be much more unusual. What happens to the brain is softening, necrosis, and infarction because of the vascular invasion. As I told you, and as is published recently from the team from India, surgery may not be a contraindication in patients with CNS involvement and may improve their survival. These are some of our patients. As you can see, after the medial maxillectomy and debridement of the trigopalatine fossa and infratemporal fossa, we have this clean MRI after 2 weeks. The other challenging patients presented to our hospital because of involvement of the necrotizing fasciitis because of mucormycosis. And this patient was hospitalized in ICU for about 1 month because of the complications of cholecystectomy. And after the necrosis of the palate, his physician decided CT scan, and as you can see, there is involvement in necrosis of the infratemporal fossa, temporal fossa, masticator space. And after the endoscopic maxillectomy, radical maxillectomy, and debridement of the infratemporal fossa, debridement of the tracheoid muscles and temporal fossa, you can see 10 days post-operation MRI here. We could not have any gadolinium-enhanced MRI because of the renal failure and high rising in his creatinine. Here is the same patient in axial view. You can see that we have extended our debridement to the tracheoid muscles here. And this is the medial and the lateral extension of our debridement was the mandibular ramus. It's very promising to see patients when they come to us after 2 weeks, after 2 years of operation. These patients had rhinocerebral mucormycosis during his ketoacidosis. You can see the orbital exentration and resection of the palate and medial maxillectomy, and that's what medial maxillectomy. And you can see he is very happy after 2 years post-operation. And I want to thank you very much. And if it's possible, I want to share my some videos here. Dr. Patel, is it possible?
If it's very short, yeah, please.
I prepare 2 movies, but I will show just one of them. You can see this patient with COVID-19 after a week after his completion of his treatment. There was orbital signs on the right side, but there is some thick mucus in the left side and crusting, which shows the involvement
I think
of
we
both,
can't see the
both
video.
sides of the nose. I didn't hear that, Professor Ashu. There was no necrosis of the palate.
Sorry, we cannot see your video. Can you please share it with us?
Oh, yeah, sure. I have to share a screen again.
Dr. Tabari,
Yeah.
would you please accept? Check
Can you
my
see?
ridiculous.
Dr. Patel.
Yeah, we can see your movie, but I'm not sure why. Yeah, go ahead, please.
Can you see the movie? Can you see the pictures?
Yeah.
Okay. The patient, I told you that the patient was ocular signs on the right side, but we find out both sides of the nose was involved with mucormycosis. As you can see, there are thick secretions in the left side of his nose. And in right side, we had the typical black necrosis of the middle turbinate and the septum. And there was not any necrosis of the palate. As you can see here, we decided to have the endoscopic medial maxillectomy, resection of the septum, sphenoidectomy, ethmoidectomy, and resection of the tracheopalatine fossa and infratemporal fossa. As you can see, this is the margin of our normal looking fat of the infratemporal fossa. This is the place where the tracheopalatine fossa was resected. This is the remnants of the maxillary nerve, and the orbital decompression and dissection of the orbital apex showed obvious necrosis, as you can see here. There's resection of the septum, and we resected some parts of the palatal bone without resecting the normal looking mucosa, which looks as an obturator between nasal cavity and oral cavity. This is the maxillary nerve and foramen rotundum, and this is the orbital content, orbital apex. You can see the normal looking fat of the anterior parts of the orbital extracornal fat, but the orbital apex was obviously involved. I usually don't dissect orbital apex, but for this special patient, because of the because we need some biopsy of the and there was some we need some biopsy of the orbital fat. I dissected here, and the patient unfortunately have left paraclival carotidescence in the left side, which we have to take care during the surgery. Thank you for your attention. I have another movie, but I decide not to. I think we are out of time.
Thank you, Dr. Tabari.
You're
Great
welcome.
presentation. And a very nice point about actually meticulous debridement of the involved area, especially in the PPF. That's a source of recurrences and intracranial extension. And
Yes.
that was a very nice point. But Dr. Tabari, personally, I'm not sure if we need to take a biopsy from the orbit when we have available and obvious actually involvement of the nasal mucosa. So can you comment on that?
Sure. We sometimes do it. I have some challenging cases. I have the movie for, there was the next movie. There are some challenging cases when there is not any obvious necrosis of the mucosal layers of nasal cavity. For example, there was 2 or 3 cases, you know that. And we just dissected the tracheopalatine fossa, and there was some sequestration of the posterior lamina papyracea of the medial wall of the orbit. After resection of that, there was, and in some cases, we didn't find obvious necrosis in the trichopalatin fossa, so we have to dissect and find it and the orbital apex for one of our special patients, his family. We do not do it always, but in very special cases with patients with no light perception, frozen eye, or some cases that we have doubt about the necrosis. Yes, it's not routine for doing that.
And another thing, if Dr. Ashok allow me, was the term orbital decompression that you mentioned about that. Again, I personally, I prefer using kind of debridement or the new terminology that's nowadays is moving forward, is endoscopic orbital exentration. That personally, I do not agree with that terminology. I'm not sure, but I think we have very critical points to discuss in the section 2. And I saw Dr. Kashkulu raised hand. If Dr. Kashkulu can just in a few seconds make his comment, I do agree. Mohsen, I do not see your raised hand anymore. Do you want to make a comment?
Farza, thank you very much. I'll go forward on the second session, right?
Thank you, Mohsen.
Yeah, I'll go forward.
One of colleagues asked me if I irrigate the debridement with amphotericin. No, we do not. We do not debride the place with amphotericin because of the evidence for the nasal cavity is low for the effect of irrigation with amphotericin. And as you know, we are lacking enough amphotericin for injection, so it's not very very cost benefit for irrigation, especially when there is not enough evidence for that.
Dr. Azan, would you do a medial decompression of the orbit in cases where there is a localized involvement by giving a periosteal incision? Would you commonly do it?
We do not do it in a routine manner because we are working as a team, and we are asking Professor Patel if he needs that, but not usually unless we need some biopsy taking, or if there is obvious sequestration of the lamina papyracea, which and necrosis of that part. Sometimes we do it, not always.
We have found it useful in those cases where there is a localized collection of non-enhancing tissue on the medial side, and our ENT colleagues have helped us. There's already been necrosis of the lamina papyracea, and opening up the periorbita to do a bit of irrigation with amphotericin B or sometimes a little debridement has been helpful to us.
You decided before the surgery, you plan to do it, or during the surgery you decide?
Those cases where we had radiological evidence of a localized pathology on the medial side, we often decide that taking the help of the rhinologist to decompress that area or to debride some tissue from that area is helpful.
It's very valuable comment. Thank you very much.
So may I now introduce Dr. Sandeep Bansal, our next speaker, who's telling us about 10 tips, rhinological tips in orbital mucormycosis. Dr. Sandeep Bansal is additional professor of the Department of Otolaryngology and Head Neck Surgery at the prestigious Postgraduate Institute of Medical Education and Research at Chandigarh, the capital of the states of Punjab and Haryana in North India. They've seen a deluge of cases from entire North India, and Dr. Sandeep Bansal, as the nodal officer for COVID-19 and mucormycosis, has been at the forefront of managing these cases. He's also very actively involved with the as fellow of National Academy of Medical Sciences and International Medical Science Academy. Is also a member of a number of associations or governing bodies, and his special interest is sleep apnea. We look forward to his talk. Dr. Sandeep.
Thank you so much, sir. At the outset, I would like to thank Professor Grover and Professor Fazad for inviting me and sharing my experiences in this August gathering. Good morning to all. So I would start with my talk on okay. Can you see my slides, please? Hello?
Yes, yes.
Yeah, okay.
Pretty good. Thank you.
Yeah, so I am in a tertiary care referral research center 250 kilometers north of New Delhi. And we have seen a deluge of patients during the second wave. We usually used to see about 40 to 45 patients of mucor in a year before this COVID struck. And since last 4 months, especially after April, we have seen around 400 patients, and we have operated around 380 patients, and 60 to 70%, even more out of them have been COVID positive. So we have this building was supposedly a building for a 250 bedded hospital, building for us, ENT, endocrine, and radiotherapy. But unfortunately, during COVID has been turned into a COVID hospital. So we have a dedicated OT for COVID positive patients and a dedicated mucor table we were having the last 3 months or so. So with this background, I would just like to start that mucormycosis is distinguished by its fulminant course with evidence of extensive tissue necrosis and should be treated as an emergency. So that is very important for us to understand as oculoplastic surgeons or otolaryngologists, that we need to understand. Now, in the last 4 months or 5 months, in a series of these 350 plus patients, we have learned some very valuable lessons. And my colleagues, Dr. Tabari has already, elaborated upon a few of those important things. So I would just like to mention a few of the lessons we have learned about and share those important points. The first is, when the diagnosis is in doubt, there's a suspected mucor case or there is a minimal disease. Usually we take a smear, which is send it for KOH mounting, or we started taking biopsies that time for KOH mount. So that was the diagnostic part for us. And then we used to treat the patients accordingly once the patient is having mucor or COVID positive or COVID negative. So the first lesson learned was that it is very important and time saving in the long run if we take an endoscopic guided punch biopsy from the middle turbinate or take a smear from the middle meatus. And during this process, if it is a painless process, because of course it is being done in the OPD procedure or in the patient's bedside. So that will, again, if it's a painless thing, it will give us a hint that, it could be we are dealing with a mucor entity of mucormycosis. So that was the first lesson learned. We could save time, like otherwise we had to send repeated biopsy if it was a blind procedure. So endoscopic guided punch biopsy from the middle turbinate or from the middle meatus helped improve their yield. Now, the second most important thing, I think, is that we have to initiate treatment at the earliest possible in the form of surgical debridement. And if there is any delay in the surgical debridement because of some logistic issues or the patient being not fit for GA, some renal issues or something, then we need to start our liposomal amphotericin and then try to work up the case and take it up the case at the earliest for the surgical debridement. And there's enough data in the literature to show that earlier the treatment, the better prognosis the patient will have. The mortality is much less, and if we start early treatment. So that's another point I would like to highlight. Now, the third thing is the key areas of residual or recurrent disease. Excellent videos by Dr. Tabari, and she has shown that they open up the pterygopalatine fossa in the infratemporal fossa. We can discuss that in the second session, that are they doing it routinely or for some special cases, or only if they find disease on the. Now, what we found in all these cases was that if we strictly go by the radiology, then sometimes we are tending to leave the disease behind, or there is some residual disease. So the key areas where the disease was left, which we had to go for a second revision or a second look in those cases, or the disease appeared later on, which was not there present clinically or radiologically, was the upper part of the septum near the skull base, the first part. So that, and in the second look, when we try to debride that part, we'll realize that because it was left for a long time and the bone, underlying bone had gone, had softened, had got dehiscence. So there was necrosis, osteomyelitic changes, and there was high chances of CSF leak. So we should be addressing that, even if we are doing an open procedure, like most of the patients were doing open procedures. So we need to do a combined thing. We need to look at the nooks and corners inside upper part of the septum, skull base, pterygopalatine fossa, sphenopalatine foramina with the endoscope. The second thing is this sphenopalatine foramen. This again is left, and then the pterygopalatine fossa, the disease used to be left because clinically or radiologically it was not there in the first case. The pterygoids, of course, the pterygoids, and the sphenoid sinus too. Like if you just open the sphenoid sinus and that's it, but we do not see any gross disease, we need to look into the sphenoid sinus very carefully. So this is again a matter of discussion, that are we supposed to open up the sphenopalatine foramina or drill the pterygopalatine or the Vidian canal at that time, or pterygoids even for that matter, can be taken up in the second session. Then we had seen a lot of perineural spread, especially if the inferior orbital nerve is involved, the neurovascular bundle of the inferior orbital nerve is involved. We found that, the IT of the infratemporal fossa was getting involved through the cheek without involving the other structures in between. So through the neurovascular bundle, as we already the V1 nerve or the mandibular division of the trigeminal, through the foramens, through the inferior orbital fissure, the disease used to reach the ITF or the intracranial disease. So there is a lot of perineural spread. So we need to take care of that. We need to see, especially on those foramina around that area, if there is any necrosis or plaquening of the tissue. So that's the lesson number 4, which we learned dealing with all these cases. Now, another thing is there is very high chances of, not high chances, high chance of CSF leak while debridement if it's a second look surgery or doing a revision, especially from skull base or sphenoid, as I already told you. So we need to look into that and see if we get, and then intraoperatively we might have to seal that CSF leak, of course, for that. So it's a very scary side because there's so much of necrosis. You cannot do a classical CSF repair because you don't want to remove the extra bone, because the whole bone might be osteomyelitic and there might be a huge defect. Now, the next thing is, we believe now that the best chance to prevent a residual or recurrence to improve the outcome is the first chance, So you have to be radical maximally, but of course judicially, The first chance is the best chance. So we need to do our best in the first time. This disease, unlike other diseases, would not give us a second chance sometimes, especially if there is a perineural spread. The spread to the infratemporal fossa, the spread to the intracranial fossas, middle cranial fossas is so fast, and then the prognosis becomes very poor. So I'm not sure about the endoscopic exenterations and endoscopic removal of the complete disease, but yes, definitely endoscopic assisted combined approaches can give us a very good chance of removing the disease at the first instance. Now, we talked about endoscopic approach. It's of course feasible in combination with aggressive medical therapy. In the indications would be limited lesion of the nasal cavity and paranasal sinuses, or if there is a limited life expectancy because of age or other comorbid conditions. For endoscopic approach, our experience is that if there is an orbital involvement or intracranial involvement, purely an endoscopic approach did not give us very good results. We need to be quite radical in that. Of course, the advantages of endoscopic approach being it's less morbid, it allows the surgeon to inspect infected tissues. We can selectively remove necrotic material and spare healthy structures. So again, endoscopic combined approach would be much better. And another thing I think which we were just discussing, in fact, Professor Grover had asked that, was mentioning that endoscopic opening up of the lamina papyracea and periorbita to rule out any involvement during surgical entrapment, so that it can help us to preserve the eye in the long run. Sometimes there is not enough evidence radiologically, but when we go inside operatively, like for example, at our institute, most of the cases are being done by us. So if we find that there was some blackening or necrosis, or the tissue was bare, then we used to open up the lamina, open up the periorbita, and see if there is any necrotic material, or maybe to inject amphotericin B. So that helped us to salvage quite a few eyes. A lot of thromboembolic phenomena has been seen during this wave of mucormycosis associated with COVID-19. Thromboembolic phenomena, infarcts of the right middle cerebral artery, infarct of the central retinal artery, maybe sparing the branch of the central retinal, but the cilial retinal, but causing the. So there were patients who had no vision, but there was no evidence of disease on the radiology, or even clinically. Clinically, they were fine, but they had no vision. So this thromboembolic phenomenon has been seen a lot during this. A lot means comparatively, of course, to our previous experience. And then last not but the least, the follow-up period, osteomyelitis of the bones have been commonly seen in the post-operative period in spite of the absence of fungal elements, the fungal culture, fungal smear, biopsies coming negative, osteomyelitis of the paranasal sinuses bones, even, the temporal bone, like skull base osteomyelitis, what we used to call as malignant otitis externa. Now we refer it to as malignant otitis. This skull base osteomyelitis has been seen associated with mucormycosis. Now it's very difficult to say or find an association, but osteomyelitis of the maxilla, osteomyelitis changes in the mandible. We just have admitted a patient with having osteomyelitic mandible changes post COVID-19, but no mucormycosis in the maxilla or in the paranasal sinuses. So that's one. And secondly, I would say that endoscopic examination and suction cleaning to be done routinely during our post-operative care, so that we can, get healthy cavities, nasal cavities. and post-operative imaging to be done only after proper suction and cleaning of the cavity. Otherwise, it can always be misleading, especially if we get an MRI done. Even the slightest of secretion and inflammation and secretions causing granulations, causing inflammation, will be very difficult to differentiate between a residual disease or a recurrence versus a normal granulation, even on an MRI, and should be done after the completion of the antifungal therapy. So the radiology post-operatively in post-antifungal therapy. Thank you.
Thank you very much, Sandeep. Great presentation. Sandeep, do you take biopsies from the nerves when you're doing debridement of the paranasal sinuses or PPF? In terms that you mentioned that it has a significant role in the prognosis or recurrence and progression. So I'm interested to know if you just check it with imaging or do you check in biopsy as well?
We have not specifically taken biopsies, but yes, when the nerves are involved or when we are removing the tissues, then definitely we have found on biopsy post-operatively that some of the nerves were involved with mucormycosis, but not specifically taken biopsies from the bit.
The other question is that, Sandeep, from time to time, we hear that our colleagues say that the mucosa sounds normal and no debridement is needed, but obviously we have intra-orbital involvement, we have sinus mucosal thickening. So I would like to ask you, and also Dr. Azin, what's your criteria for actual debridement in the paranasal sinuses, PPF, and skull base? What criteria do you consider this mucosa needs to be removed or not?
I would say it's more of an experience kind of thing. Like if it is radiologically involved, definitely it needs to be debrided. But sometimes, once you are into the sinuses with your endoscope, you feel that like we have been doing paranasal sinus debridements. So if it is not looking like a normal mucosa, or if we feel that it is, then we definitely try to take tissue from that part of mucosa to send it separately for biopsy to see whether if it is, so that the follow-up can be even better. But like we just can't be very radical. That is why I say we have to be radical, but judiciously, not harming the patient in some way or the other. So we take separate biopsies, keep it separately and send it for biopsy. If it turns out to be mucor, then we keep a very close watch because antifungals are anyway going on.
Mm-hmm. Dr. Tavares, do you want to make any comments about this question?
Yes, as Dr. Bansal mentioned, yes, I think it's all about the experience of the center who is working on the mucormycosis. And if the clinical signs and symptoms are typical of mucormycosis, and especially the history match the COVID-19 infection or corticosteroid therapy or having diabetes, it's better to investigate those areas or like Trigo-Palatine fossa. Besides, there are patients who we encountered. It seems to be normal mucosal nasal mucosal, but when surgeons or physicians who are experiencing this part, even this normal mucosa, if we take biopsy, it might be positive in cases. So I think we have to consider, especially in, nowadays, we have consider mucormycosis. We have to take biopsy even from the normal looking mucosa, and if it's not, if it's negative, as you mentioned in your slides, we have to take a rebiopsy, and we have to investigate other places like Trigo-Palatine fossa.
Thank you very much.
You're welcome.
So, Dr. Ashok, do you want to introduce the next speaker and say something about the emergency thing that happened?
Yes, Dr. Deepak has requested for speaking the next in view of an emergency that has come and he needs to go. I would like to take this opportunity to request him to tell us about the neurosurgical and neurological involvements in the COVID-associated mucormycosis. Dr. Deepak Gupta is the professor of neurosurgery at the All India Institute of Medical Sciences, which is the apex institute of the country. And he's an adjunct faculty of the Indian Institute of Technology, Delhi. He's had an extensive involvement in the clinical care of patients of cerebral mucormycosis and is a renowned figure in the country. We look forward to his speech on this aspect. Dr. Deepak.
Thank you. Thank you so much, Dr. Grover, and the entire team and the entire organization for this opportunity. Sorry for jumping the queue because I have to rush for an emergency right now. In contrast to the previous speakers, I would say my experience is quite limited because we see patients who are referred to her primarily by our ENT or a rhinology department or from the ophthalm department, those who manifest with the cerebral manifestations. So in all, I have a personal experience of just 8 cases, I would say. And prior to this COVID pandemic, we as neurosurgeons used to see more of aspergillus infections. I don't recollect if I ever operated in the last 2 decades of my practice cerebral mucormycosis cases in my institute. But yes, if you ask me, does cerebral mucor or did cerebral mucor existed in the pre-COVID era? Yes, it did. And countries like Asia and Europe, the incidence of almost 28 to 34% has been reported, with the least incidence reported in the Australia and the New Zealand. So it's not that it is a disease which is a part and parcel of COVID. It has been existing before, and primarily these fungi, they are kind of they are in the plant debris, soil, and other stuff. Another interesting thing I want to bring to the notice, I'm sure many, Dr. Grover will agree, that it has been wrongly labeled by almost anybody and everybody in this pandemic. It's been synonymous with black fungus, which is actually not so. In fact, there have been few articles, newspaper clippings, media reports, wherein this unfortunate fungus has been given varied names, beginning with the black fungus, white fungus, yellow fungus, and whatnot. While we know that the black fungus is actually caused by the dermatoschisis, which is actually infection of the skin and other paranasal sinuses, and not the mucor infections. So I usually call it, say, a rainbow color being given in the time of the COVID pandemic to this fungus. Yes, it has got very acute and rapid progressive infection. Most of the things have already been covered by my previous esteemed speakers. But I think the most important thing we have to understand, the outcome of cerebral mucor is not good, primarily because of the late pickup. We have to understand that majority of these patients are in the COVID setups, COVID confined setups, which are primarily managed by the residents and the young chaps. And I would say they had very less kind of a exposure to the early diagnosis of these cases. And I believe that large number of patients who succumbed or who worsened, they occurred because they were diagnosed late, because your eye sees what your mind knows. If some resident or an intern is posted in the COVID setup and he has to manage almost 30 plus patients in one particular ward, and if he has no clue to pick up those subtle signs of infection, naturally the disease will progress. And this is actually that has happened, which has led to poor outcomes in this pandemic period. The means of spread have already been covered. Yes, it comes in the advanced stage of the COVID infection when the brain actually gets involved. And so yes, I do agree that fungi are kind of interface between life and death, and this actually holds true when a person transits from the a rhino-orbital stage to the rhino-orbital-cerebral stage, and it's a matter of life and death, I would say. Our department has actually come up with the so-called early sentinel signs, because when we started having very high incidence of mucor, so there was a cause for worry. And then we came up with certain checklists and guidelines for our young team members managing COVID patients. And one basic thing I used to teach to my residents was, in case you have somebody with multiple cranial nerve involvement, third, fourth, sixth, with loss of vision, think of mucor. And because most of the bacterial infections, cellulitis, which previous speakers showed, they usually don't have loss of vision. So that is one easy way to make out whether it's a mucor or not prior to the diagnostic investigations. This has already been covered, so I'll skip it. Differential diagnosis, we all know, mostly we have to rule out other fungal sinusitis, aspergillosis, and cellulitis. The management from the neurosurgeon's perspective, I would say, yes, we have to take a standard three-pronged approach, which includes reversal of the immunocompromised state, administration of the antifungals, and of course, aggressive and extensive early antifungal or surgical debridement. The hyperbaric oxygen therapy was, I think, touched upon by one of my previous speakers. I'll skip it in the interest of time. I'll just show you a couple of cases which I operated. And this was the first girl I operated. And you see, we have to look at various logistics. We have a COVID center almost 60 kilometers from the main hospital. And this young girl, not a known case of diabetes, but during admission, she had a high HbA1c. And she was normal. She had some subtle changes in the sensorium. That was the first early CT scan which you see. And she was in a COVID confined setup with no access to neurosurgeons. And so subsequently, she had a bleed in the basal ganglia. She was actually shifted to our main AIMS neurosurgical hospital from the COVID center in NCI. And because she came in decerebrating state, so we just removed the bone flap as a part 1 of the surgery. And 48 hours later, when the patient improved to M5 status, we actually went ahead and removed part of the hematoma was taken out, and the abscess which was there in the basal region was removed. And this patient started improving, and these are the intraoperative pictures, a large basal ganglia hematoma, and this is the kind of grayish to blackish areas at the skull base seen from the intracranial window you can see out here. And these are a couple of short videos I'll show you. And this is the hematoma being taken out, and you can see this purulent material coming out from the anterior cranial fossa region. Some more hematoma. And subsequent to this stage, we took help of our ENT colleagues. And yes, this lady, she had some debridement done from the sinuses, and she did reasonably well. But then the abscess reformed, and we had to re-excise the abscess. And unfortunately, this lady succumbed from the ruptured abscess and from the bacterial ventriculitis. This was the abscess which actually reformed in this patient. And this is the only patient actually we have lost. Couple of some other cases. So this abscess can be in any other location, can be in the temporal region, and can be in the anterocranial fossa. And a few cases we did not do any exenteration, and some cases our team they did the orbital exenteration. Like this patient, the orbital exenteration was actually carried out. So these are the details of most of the patients. I would say 6 out of 7 patients, they had uncontrolled diabetes. All of them were on steroids, and all of them have antecedent history of COVID infections prior. So I would say in the pre-COVID time, prior to the, I would say, availability of the amphotericin, the mortality in these infections were almost 100%. But with the advent of amphotericin B, we have something like 20% survivors with the disease spreads to the brain. And of course, the risk of disfigurement, we have been talking about orbital exenterations and other things, is always there with the patient. The patient need to receive antifungals for a very long time. And the most important thing we have to understand, which we are not talking, I don't know how is the state of affairs in your country, but when the second wave hit her, like our health system was totally overwhelmed. We had delayed in diagnosis I would say, mucor cases, because primarily it is seen by the ENT colleagues, and ENT colleagues are not always present in the dedicated COVID centers. They are primarily managed by the young people who may not have any idea or a high risk of suspicion of these infections, right? And we have to admit, despite the availability of all the resources in any nation, we fell short of amphotericin B, and there was a huge amount of UN crisis raised. So the drugs were not available in time. If they were available, patients were getting not the adequate dose at the right time because there were really too many patients. So all this kind of led to utter chaos and did have a significant impact on the morbidity and mortality in, I would say, in the month of April, May, and early June. I would say, as a neurosurgeon, my take, what I have understood from this in the last few months, is not black fungus. First of all, let's be very clear. And it is not a COVID-specific disease. It can occur. It used to occur before, like Dr. Bansal mentioned. They used to see almost 40 plus cases every year of mucor in their practice. So it's not a COVID-specific disease. And yes, it is seen in uncontrolled diabetics. So that is one of the very strong factor which has come up. India is almost, and I would say, endemic for diabetes. Almost 50% of our population is diabetic. So we need to watch out. Most important thing we have to know is regarding the COVID positive status. Though yes, it occurs almost probably 1 to 2 weeks after the COVID infection. So RT-PCR may be negative. But in some cases, the RT-PCR may still be positive due to the compromised immunity or delayed clearances. So it is not uncommon that patient may be RT-PCR positive. So patient need to be managed. Okay, just the last slide. So yeah, you need to test for the RT-PCR status even in these patients, and it can be fatal if it is not treated early, and it's a multidisciplinary disease. The strongest message I want to give to the listeners here is that we need to really work upon increasing awareness amongst the public, amongst the healthcare workers, and of course the easy availability of the drugs. We have to understand that we at this platform, neurosurgeons, ENT colleagues, and ophthalmologists, we may not be posted in the COVID facility 24H. And the younger lots, they need to be told the very early signs of pickup of these infections for early diagnosis, early referral, and early treatment. Thank you so much. That's my alma mater. That's All India Institute of Medical Sciences in New Delhi. Thank you so much.
Thank you, Dr. Deepak, for making some very pertinent points regarding the disease and giving us the perspective of a neurosurgeon. You spoke particularly about the debridement that you need to carry out in those cases which go on to abscesses. But there are a number of other cases where there is a cranial involvement, intracranial involvement, including those who just have cavernous sinus initial disease going on to involvement of the vessels and with the throwing out of the infarcts and so on and so forth. So at that stage, what do you think is the most important thing that we as clinicians, rhinologists, and orbital surgeons need to do in terms of our decisions regarding the debridement of the orbit or debridement of the sinuses?
Yeah, so basically, we see the indications of neurosurgical interventions, I would say they are quite limited. You have some patient with a brain infarct or a developing abscess or a hematoma. Yes, those are the indications. Otherwise, we all know cavernous sinus involvement is pretty common in these patients. So in those cases, I would say that one needs to stick to the COVID or the mucor basics of taking care of the disease burden or the disease load from the nose and from the orbit. And of course, early institution of your therapies, early amphotericin B in the right and the apt doses, and posaconazole later on to be added. I think that's all that needs to be done. The thing I have learned, Dr. Grover, many people, I have not mentioned data of the patients who actually did not reach me, because I used to get call for, urgent neurosurgical intervention. And before they reach me, they used to lose them. So I think it's the high index of suspicion has to be there. Those you can analyze your disease in a very subtle manner, like my previous speaker talked about spread of the disease along the nerves. Yes, it can occur. cavernous sinus involvement, yes, it has been documented. Third, fourth, sixth, fifth, they are the ones which are primarily involved. And if you have those early subtle signs, you need to be very aggressive in your monitoring and regular review. It's a multidisciplinary disease. Primarily, we know that it's a disease of the otorhinolaryngologist and sometimes of the ophthalmologist. So it's ENT colleagues who kind of take the spearhead in managing this disease. And I think they need to be kind of primed about pickup of those early signs and symptoms. Any patient having some visual impairment or having some kind of paresthesia or hypoesthesias in the V1, V2 distribution, seizures, altered sensorium, even headache. Like the first lady I told you, a young 33-year-old girl, she was in the COVID isolation in a dedicated center. And I would say they lost almost 72 hours in shifting her. And she was shifted only when her sensorium started dipping in. We have to introspect how many people, how many consultants are actually present physically inside the ICU to see those patients. None, practically none. Who sees the patient? It is the residents. And do you think the residents, those who are just MBBS, they will have this enough knowledge about pickup of this cavernous sinus thrombosis, MCA thrombosis, carotid artery thrombosis? No. So the only way we can save life, we have the expertise, we have the good kind of ENT surgeons, eye surgeons. We're talking about the advanced TREM and other injection therapy, agreed. But why are we losing the patients? We are losing the patients because we are not able to diagnose them early and we are not able to give them adequate therapy at the right time. That's the only thing I want to say. This is my observation.
Thank you for making all those very pertinent points. I think when we see early signs of involvement of the cavernous sinus, we often tend to veer towards a debridement or going for an exentration in our cases. And of course, the nasal and the sinus debridement and surrounding areas is the primary therapy that is done at the earliest when a confirmed diagnosis is made. But a decision regarding exentration is the one which often hinges on our suspicion of earliest involvement of the cavernous sinus or a great predisposition when we find apical involvement or involvement of the superior ophthalmic vein or other signs which suggest that there could be an intracranial extension. So those are often the earliest clues for us to go in for an exentration. Thank you for making those wonderful points. Over to Fazal.
Thank you, Ashok. Thank you, Dr. Deepak. I have two quick questions for you. So when we are talking about mucormycosis, we consider to do an aggressive debridement of the necrotic tissue in the nasal cavity, in the paranasal sinuses, in the PPF, in the orbit. But when we come to the brain, when we are seeing obvious necrosis, obvious abscess formation inside the brain, my feeling is that my neurosurgeon colleagues are reluctant to do any surgery for these cases. I'm not sure why, because the nature of the disease shows that we should be very aggressive in the early stages of the brain involvement. I'm not sure if the source of that reluctancy if is kind of the belief that the CNS involvement equals the poor prognosis or something else. Can you help us to elucidate that situation?
Yeah, so a good question. So basically, it is not that the neurosurgeons, setup are scared. It may be that the patients there are reaching late. Let us say if the GCS or the Glasgow Coma score of the patient dips. So majority of these patients have got extensive brain swelling and they have got severe amount of cerebritis or inflammation. Like in the first case which I showed you, when the patient was shifted to us, I did nothing. We just removed the bone plug. That's it, just to relieve the pressure. And 2 days later, when the patient improved, we went back again and we did the drainage of the abscess and removal of the hematoma. Later on, when the abscess was well formed, then we actually went ahead with the kind of excision of the abscess. So I would say one needs to take a balanced approach. see, neurosurgery, like I would say in the COVID times or the mucor times, is like management of a patient of a severe head injury. We don't need to be super radical, but we need to be early. So if somebody can operate and at least drain or marsupialize the abscess and give some amount of space to the brain to breathe, to pulsate, I think that should be enough. And rest of the work will be done by your debridement from below and by your antibiotics. So yes, if there is a definite lesion inside the brain, an abscess forming, mass effect in the brain with a good GCS. If you have a patient who is decerebrating M2, we invariably know that this patient is very unlikely to make it by now because the disease has already caused a lot of endarteritis and vasculitis. And so in those cases, they may not be very, very keen to doing. At the end of the day, it is the patient who tells you whether he or she should be operated, deserves treatment or not. That's what my take is. So I am very aggressive in my approach, but then at the same time, I'm very selective. And we need to decide, nobody wants somebody to die in their surgical hands, especially when it comes to the intracranial spread. And if I've shown you 7 cases, out of 7 cases, 6 patients have been discharged home with the intracranial spread. Only 1 patient died, and that too from the bacterial ventriculitis, not from the mucor. She improved. After 3 months later, she died. So it is not true that all patients with the cranial spread, they die. It is not true. I don't agree to that.
One of the grave things that happened to mucor cases is the ICA thrombosis. So following the hint that Ashok beautifully mentioned, the involvement of the cavernous sinus and the involvement of the ICA in the carotid siphon, do you believe we should be we should think more aggressively about the debridement of the cavernous sinus in terms of prevention from extension to the ICA?
Yeah, of course. If that's why we have been talking right from the first slide, and all the previous speakers have emphasized the need for early diagnosis, the sentinel signs, and early intervention. If the ENT colleagues and the opthal colleagues are able to kind of, attack the disease very early, and of course with the early antifungal therapy, then those things don't come. Once the disease spreads and starts causing, it's a ferritin loving and kind of angio loving mucoral molecule. We all know that, the fungi. And anywhere in the body, when the vessels get affected, the consequences are quite catastrophic. So cavernous sinus involvement, the ICA, carotid artery thrombosis, they do occur, and the consequences are not good. I'm not trying to give a very rosy picture that all patients who come to neurosurgery, they survive. It is not true. But what I'm trying to say is that this is a multidisciplinary disease, demands early pickup, and early extensive debridement. And you are the guys who are responsible for handling it. And I think your society should take at least one important step of increasing the awareness, especially to the doctors who are working in the COVID setups. I don't know how is the COVID managed in your country, but when you have got tons of patients loaded, so it's the youngest colleagues who manage COVID, and it is where they are likely to get missed. That's what I believe.
Thank you, Dr. Deepak. Great presentation. Thank you very much.
Excuse me.
Is there any question?
Hello, everyone.
Do you have any questions, Dr. Khodavesi?
Yeah, can I ask a question?
A quick question, please. Very quick.
Yeah. Thank you, Dr. Gupta, for your nice presentation. As you mentioned, the incorrect terms of black fungus, popular from India to the world. But we have several challenges in Iran with this incorrect term. I've questioned, do you scientists from India for correct this incorrect terms to mucormycosis, because we have several challenges here that is incorrect name and this is popular, but unfortunately we can't describe about this.
So see, I have kind of talked at various public and government platforms, and I'm very radically talking about it. It is not black fungus. You know, we all are kind of, you know, if you talk to the mycologists and microbiologists, black fungus does exist, but it is something different. Okay, so every fungus has got a terminology. They need to be deserved and respected by their correct names. So what actually happened was the first case which were reported from Mumbai, Lilavati. So this ENT surgeon probably was interviewed, and probably he talked about this black eschar and black discharge and other things which coming out. And he was a gentleman who actually talked about it being a black fungus. And then the name spread like fire. So from the prime minister to the junior most person in the country, and even the lot of medicos and doctors, they interchangeably use it as black fungus. It is not. It causes black sloughing because of endarteritis. We all know that. So let's not get carried away by the name. We need to understand it's a very aggressive fungal infection. It causes angioinvasion. It causes metabolic derangements. I'm sure next speaker will be talking about it. And they are the ones which need to be talked about and addressed.
Thank you. Thank you very much. So we will move on to the next speaker.
Thank you so much. Thank you so much.
I would like to invite Professor Nushin Shirzad. She's a professor of Tehran University of Medical Sciences in Imam Khomeini Hospital Complex. And she's endocrinologist. I would like to invite her to start his presentation regarding the what's the role of metabolic state before and after COVID-19 and mucormycosis. Dr. Shirzad, the stage is yours.
I'd like to thank Dr. Patel for inviting me. It's my pleasure to participate in this webinar. Thank you very much. I share my slides. Okay. I'm going to focus on the role of metabolic state before and after COVID-19 and in mucormycosis. Okay. The agenda, you see. As was mentioned by my colleagues, mucormycosis is an uncommon life-threatening fungal infection that occurs mostly in immune-compromised patients, and diabetes mellitus is as an independent risk factor for both severe COVID-19 and mucormycosis. Uncontrolled metabolic conditions, especially diabetes mellitus in ketoacidosis and corticosteroids, are the most important predisposing factor in the development of COVID-19 associated Rhino-Orbital-Cerebral Mucormycosis. As you see in this graph, 72% of 418 cases of mucormycosis were diabetic patients. And the first topic in agenda is the various components of metabolic syndrome. As you see in this algorithm, metabolic syndrome includes the following components: central obesity, systemic hypertension, insulin resistance, and atherogenic dyslipidemia. And in this figure, you see metabolic changes and their sequence of occurrence in an obese diabetic female. By increased adiposity, we have increased adipokines and free fatty acid, then causes obesity, high blood pressure, diabetes mellitus, and dyslipidemia, and finally, metabolic syndrome. In this figure, you see excuse me. You see the metabolic rearrangement and epigenetic changes that promote diabetes by energy imbalance that resulting from high calorie food intake and insufficient metabolic activity leads to increased BMI and sets the stage for metabolic rearrangement that influencing lipid and carbohydrate metabolism, ultimately leading to insulin resistance and dyslipidemia and type 2 diabetes. The second topic is endocrine and metabolic aspects of the COVID-19 pandemic. In this figure, you see different endocrine that can be affected by COVID-19. For example, possible hypothalamic pituitary dysfunction and alterations in anti-diuretic hormone metabolism and sick butyrate syndrome, or probable higher susceptibility to COVID-19 in adrenal insufficiency and Cushing syndrome. In bone, we may have low vitamin D may be linked to more severe disease and increased risk of hypocalcemia. And higher susceptibility and worse outcome have been reported in men, in diabetic patients, and in obese patients. You see potential obesity implications mechanism in coronavirus disease 2019. In an obese patient, we have many complications by COVID-19, such as immune dysfunction, cardiometabolic disease, pulmonary disorder, heart disease, kidney disease, endothelialitis, and hypercoagulable state. You see in this table, many disorders that we see in patients with COVID-19 in an obese patient, such as insulin resistance, prediabetes, and type 2 diabetes mellitus, chronic and excessive activation of the sympathetic nervous system and RAS system, systemic hypertension, atherosclerotic and non-atherosclerotic CVD, hypertension, and obstructive sleep apnea, and pulmonary arterial hypertension, or hypercoagulable state, or increased risk for cancer, or such as colon, gastric, etc. In this figure, you see putative mechanism contributing to increased susceptibility for COVID-19 in patients with diabetes mellitus by higher affinity cellular binding and efficient virus entry by increased expression of ACE2 and decreased viral clearance and diminished T cell function and function of neutrophils and macrophages, and increased susceptibility to hyperinflammation and cytokine storm syndrome by delay in the initiation of adaptive immunity and dysregulation of the cytokine response. And because of presence of CVD, we have more complications. The third part is risk factor for mucormycosis in people with COVID-19. There are some risk factors such as hypoxia, high glucose in diabetes, new onset hyperglycemia, or steroid-induced hyperglycemia, acidic medium by metabolic acidosis or diabetic ketoacidosis, high iron level by increased ferritins, and decreased phagocytic activity of white blood cells due to immunosuppression by COVID-19 or steroid-mediated or background comorbidities, and several other risk factors such as prolonged hospitalization with or without mechanical ventilators. The last part is number of triggers that may precipitate mucormycosis in people with COVID-19 in relation to corticosteroid, such as uncontrolled hyperglycemia and precipitation of DKA due to corticosteroid intake. Low pH due to acidosis is a fertile media for mucospores to germinate, and steroid use reduces the phagocytic activity of white blood cells. And other factors, COVID-19 causes endothelialitis, endothelial damage, thrombosis, lymphopenia, and reduction in CD4 and CD8 T cell level, and thus predisposes to secondary or opportunistic fungal infection. You see in this algorithm, part of the algorithm, the free available iron is an ideal resource for mucormycosis, and hyperglycemia, as you see, causes glycolization of transferrin and ferritin and reduces iron binding, allowing increased free iron, as you see in this part. And on the other hand, increase in cytokines in patients with COVID-19, especially interleukin-6, increase free iron by increasing ferritin levels due to increased synthesis and decreased iron transfer. And concomitant acidosis increases free iron by the same mechanism and by reducing the ability of transferring to chelate iron. And finally, high glucose, low pH, free iron, and ketones in presence of decreased phagocytic activity of white blood cell enhances the growth of mucor, the expression of glucose regulator protein 78 of endothelium cells, and fungal ligand spore protein, homolog protein. They are enabling angio invasion, hematogenous dissemination, and tissue necrosis. And now you can see this algorithm that I mentioned all of the events on the previous slides. As a summary, increase in mucormycosis is due to rampant use of corticosteroid by increasing blood glucose and opportunistic fungal infection, and COVID-19 by cytokine storm, lymphopenia, and endothelial damage. All efforts should be made to maintain optimal hyperglycemia, and only judicious evidence-based use of corticosteroids in patients with COVID-19 is recommended in order to reduce the burden of fatal mucormycosis. Thank you very much for your attention.
Thank you very much, Dr. Shirzad. Great presentation. And you actually educated us with many molecular mechanisms of the hyperglycemia and diabetes in COVID-19, and also about mucormycosis. So you feel that gap of knowledge for us to actually associate these two entities. Thank you very much. So I'm not sure.
May I just add a couple of words?
Yeah, sure.
I think that was an excellent presentation, and gave us a very good clue to why we may have had the epidemic. I would just add one more factor as to why it has particularly affected some of us in the Indian subcontinent, Iran. The possible reason is our tropical climate in many parts of this part of the world, where the fungal incidence, as it is, fungal diseases is more than what it is in, say, in more temperate countries, particularly in the US and Europe. And that, along with the existence of a number of spores, the dust counts, the air quality index is quite different in our countries. And the number of spores that are inhaled by us may be much larger. So add to that the hyperglycemia, newly induced or pre-existing, along with all the metabolic changes that she spoke about, may be why we've had such a high incidence of this condition in COVID disease.
Thank you, Ashit. Great comments. So we now move on to section 2. I would like to invite moderators of section 2, Dr. Salehi, Dr. Vagefi, and Dr. Sandeep, to take position for moderation the next session. So in this session, we will have interaction with the audience and hear their questions and comments. And also we have great presentations by dear colleagues, Dr. Tarjani and Dr. Sandeep, with great experience in mucormycosis. So stage is yours, Dr. Salehi, Dr. Sandeep, and Reza.
Thank you, Dr. Fazal. So the first presentation is, who's going to present the first?
Dr. Tarjani, you may invite her.
Yeah. So Tarjani is ready with her slides. Thank you. Thank you, Dr. Tarjani.
Good morning. Am I
a word of introduction for Dr. Tarjani.
Yeah, I think so. I was going to say, Dr. Ashok, to please introduce Dr.
So Dr. Tarjani is an excellent and very versatile oculoplastic surgeon at the prestigious L.B. Prasad Eye Institute in Hyderabad in the ophthalmic plastic surgery services. And she is also an honorary adjunct associate professor at the University of Rochester. She's done such tremendous work in all fields with a lot of initiative in developing newer technologies that it is always a pleasure to hear her. And the amount of work that she's done in mucormycosis, she's already had a couple of publications, including one on the radiological manifestations in mucormycosis, that we really look forward to listening to Dr. Tajani.
Thank you so much, Professor Ashok Grover and Professor Pakdal, for having me at the meeting. I hope I'm audible.
Yes.
Yeah, right. So without much ado, I'm going to go straight into the case that I'm going to discuss. And I want to bring out 5 issues of interest as far as this case is concerned. You see them listed on your right-hand side. So I'll go through these one after the other as we go across the cases. I want to highlight the role of a quiet eye with a lurking abscess behind. When you're imaging, what is the role of fat suppression sequences, and how do you assess loss of contrast enhancement, and how does that affect your decision making, clinical versus radiological resolution, and finally going to leave the audience with a question from my end on what you do when you have bone involvement. So this is my patient. He's a 47-year-old gentleman, a known diabetic for the past 2 years. He was on insulin and very well controlled with insulin. You see his blood reports here before COVID struck. And he's been a very regular at getting his blood sugars checked and being in touch with his endocrinologist for metabolic control of blood sugars. Now, he developed COVID infection on April 8th, 2021, this year, the second wave, and had a little bit of dip in the saturation on room air. He developed a little bit of lower respiratory infection for which he had to be admitted and received IV steroids, methylprednisolone in the dose of 40 milligrams twice a day for 5 days. He also received oxygen and he was discharged in 2 weeks, hale and hearty after the COVID infection. However, 2 weeks after his discharge, he developed dental pain and he started having unbearable amount of pain, for which he visited his ENT surgeon and his max fac surgeon. Imaging suggested signs of invasive fungal sinusitis, especially centered around the maxillary and the ethmoid sinuses. He was advised a CT scan, which I do not have. All of this is prior to his ophthalmic presentation. And he underwent surgery in the form of a sinus debridement and dental extraction and peripheral ostectomy around the alveolus in the upper and the lower jaws, somewhere in mid-May. After all of this, he had a histopathology diagnosis of confirmation of mucormycosis and was on liposomal amphotericin B for 2 weeks in an appropriate dosage, following which he was started on a bridge therapy of posaconazole and amphotericin B, and then was on oral posaconazole while he presented to us. So COVID history of 2 weeks, sinus history of 2 weeks, and then 2 weeks later, he comes with right eye edema and inflammation and pain around the right eye with a little bit of ptosis, as you see in this picture, and some amount of proptosis. So it's a relatively quiet eye, but you are starting to see signs of the infection around the eye. He maintained 20/20 vision throughout his treatment period. We reviewed his history and most of it I have presented over here. He had raised systemic inflammatory markers, his D-dimers, ferritin levels, IL-6, everything was over the roof. And then we took a look at his imaging. So this is him at presentation, and I'm just going to pause here for a bit. You see some evidence of debridement that has been done. And if you look at the right orbit, then you have a lot of fat stranding with the disease possibly centered along the inferior half of the orbit. The superior half is also not completely spared, but then the inferior half seems significantly worse. You see distortion of the extraocular muscles and some amount of involvement over there. Now, just to go back a little bit, I'm going to pause this one for a bit. And why the pre-op imaging is so important, or going through the imaging is so important, is to actually look at these red flags. Now you see this area of loss of contrast enhancement here. This is an area where no amount of drug is going to reach, whether transcutaneous retrobulbar or IV antifungals. So this was him on presentation. He had to have repeat sinus debridement for leftover sinus disease. And along with that, he was given transcutaneous retrobulbar amphotericin B. This is him following the amphotericin B. And you will be able to see over here that despite the amphotericin B, the necrotic area persisted. So that's the first learning point that I wanted to see, that just the amphotericin B is not going to work on the necrotic area. And then we took him up for orbital debridement. And this is him post-orbital debridement. And if you look at the orbit here, it looks worse. This is how it looks in the initial period. There's more amount of disease than what you see in the pre-op scan. There's more amount of crowding around the nerve, but then that necrotic area has gone. So this was his treatment, where we repeated the sinus debridement when he came to us. We gave him transcutaneous retrobulbar amphotericin B, and we took care of that necrotic area via an orbital debridement and followed him up over a period of time. This is him 2 months later. You see a resolution in the proptosis. To some of this is probably because of decompression of the floor of the orbit, but disease-wise, he was stable at his 2 months visit. So coming back to the 5 points that I had listed, this was him at presentation. It looks like a very quiet eye, but you need to pick up that necrotic area, and your management essentially will revolve around whether you see contrast uptake or you don't. Now, what are the imaging sequences you need to see? This is the same patient, similar cuts, but you see the role of fat suppression. When you suppress the fat, you're able to pick up the disease much better than when the fat is not suppressed. So that's the sequence that you want to look at, fat suppressed sequences. In my opinion, T1 or T2 weighted post-contrast fat suppressed images are the best images to sort of give you a clue about the kind of orbital involvement that you see. So you'll see the dates. These are 3 subsequent scans where necrotic area present with TRAMB, necrotic area present, absent after debridement, though the disease might look sort of more, but what you go by is assessment of whether there is any necrotic area or not. And this was him, the clinical resolution after 2 months and the radiological resolution. So there's always a lag in radiological resolution. You see faster clinical resolution than radiological disease resolution. And that's one thing that we need to remember and is an area of research. Now, the other part in this patient, which is an open question to the house, is these are his axial cuts, and I want everybody to focus on the zygoma and look at the area around the zygoma. And you can see the dates on the top here. So there's progressive worsening in this area around the zygoma, though the inferior orbit has improved. So what is the next step now? Does this patient require a debridement of the zygoma, or does it require an excision of the bone? And what's the best way to go ahead with that would be the question. Since we are short of time, I'm going to rush through these last 2 slides and would urge everyone to go through our recent work on mucor, especially the one on imaging, and would love to have all of you visit us at some point of time in future. Thank you so much.
Great case and nice questions. So Dr. Sandeep and Dr. Reza, you may circulate the challenges and questions to the panel.
Of course. Congratulate you on that save. That was, it was well treated, and I think for us, we would have done very similarly, that we would classify this as stage 3 disease, where you have, in addition to the inflammation, focal area of loss of contrast enhancement that's extraconal that can be debrided. So I congratulate you on saving this patient's vision and probably his life. So as far as the area of it looks like there's also temporal muscle involvement in that last picture there. And I would presume that you would need to go and do some form of debridement Do any of the OHS colleagues have an opinion here, or with their experience?
So I would suggest to review the diffusion weighted imaging to make sure we are confronting with kind of inflammation, or we are confronting kind of necrosis, osteonecrosis. Maybe we have involvement of the zygomatic facial bundle there. So I would suggest to take DWI to make sure if we have necrosis, we should go for debridement. Otherwise, we may continue IVM for fossa and maybe a local injection of that things.
Right, thank you. So the other question there, Dr. Pagdel, was if you consider a debridement of the bone, what would be the approach here? Would you like to go from the orbital side, or would you like to go Calvin lock and approach the zygoma from the oral cavity, or possibly do an overkill and raise a coronal flap and go in and make sure that the entire zygoma is debrided?
So Dr. Tarjani, I assume this is a tough case because I observed that in the third slide, you showed us that you have removed the whole septum and the right heart palate as well. So it shows that we are facing a case with progressive mucormycosis, despite assumably adequate debridement in the first and second stages. So yes, I think if it shows to be even small necrosis, we should be very aggressive and go for debridement and osteotomy over there.
Thank you.
I would second that. I would favor a more radical approach with the excision of the bone and debridement of the entire area quite well, considering that there has been a progression, and I feel there would be necrotic tissue there which needs to be taken care of.
Right, thank you, Professor Guru.
Absolutely.
And can I make another comment and question? Do you have any photo of the third actually MR? I would like to know if the patient is showing some kind of the hemifacial swelling or the features of the necrotizing fasciitis or not.
Yes, that's an excellent point. So he, unfortunately, it's cropped here, but yes, he did have some amount of temporal swelling, soft tissue swelling, but no hemiplegia or other neurological signs. So while his eye looked better, but yes, the temporal fossa swelling seems to have increased now.
In this case, we should be very aggressive and treat it like, necrotizing fasciitis. We need to open all fascia and actually aggressive debridement of the whole temporal and pre-parotid and parotid area, as I see here. As Reza beautifully mentioned, we have kind of involvement temporal fossa.
Right, right. Thank you.
Can I raise a question? Like, it's a totally different thing, and looking at the excellent presentation and radiology from Dr. Tarjani, I'm tempted to ask this to Dr. Tarjani as well as to the panel. Like, we are talking about ideal conditions. Ideally, MRI is the investigation of choice for mucormycosis, especially the fat suppression images, as you have shown, which gives us a very clear demarcation between the disease process which is happening. But if you're talking about developing countries, if you're talking about places where there is a deluge of patients, and there are 40 patients waiting, 30 patients waiting for surgery, like, is there any role of a CT scan for mucormycosis? Because doing a MRI, especially 70-80% of the patients were COVID positive during May, April late, and May, June in our center. So MRI would be, logistically just not possible. So what is your take on that?
Thank you, sir, for the question. So in my opinion, when it is, where you want to screen whether there is any paranasal sinus involvement or not, it's okay to use a CT scan. But then to make your management paradigm, you depend a lot on looking at what is happening post-contrast, whether there are necrotic areas or whether there's good contrast uptake. If there are necrotic areas, we know that no amount of antifungals, whether local or systemic, is going to reach that area. And hence, in my opinion, MRI sort of becomes the cornerstone for managing these patients. So we've had a few such issues where the cost was a factor, the time taken was a factor, but we've tried to negotiate around it to develop MOUs with centers where they receive all our load of patients. So the paying patients also they receive, but then they're obligated to help us with our non-paying patients as well. So that would be my take on it. The other areas where CT scan specifically can help is such situations of osteomyelitis, one. And second, sometimes, though most of our ENT colleagues operate based on the MRI, but some might want to use a CT scan for sort of better clearance of the sinus. And eventually, once the patient is completely cleared of mucormycosis, maybe for prosthetic rehabilitation, we might want to look at a CT scan. But other than that, we've not had trouble in getting MRIs for most of our patients.
No, the cost is never a factor in PGI, maybe. In fact, nobody in private was doing any COVID work. It is only the government sector hospital which are doing COVID work. And having a MRI scanner in a COVID hospital, CT is, we could barely manage a CT scanner for a dedicated COVID hospital. So doing for MRIs, so it is not about cost. Like, would a contrast enhanced CT scan suffice us or be adequate to give us treatment planning or a algorithm or a paradigm for the management of mucor, or MRI is a must? That's what I'm interested, because then we need to make changes, whatever said and done.
Dr. Bansal, I understand your concerns here as far as the availability of MRI at some of the hospitals. We actually performed a study back in 2000, actually not me, but my colleagues in neuroradiology at UCSF, and looked at MRI versus CT. And MRI was shown to have a greater sensitivity, around 85% compared to around 60%, 70% for a CT scan in detection of early invasive fungal disease. So that's the critical part here. If we're going to be early in our intervention and really jump on the infection, you have to be able to detect it as soon as possible. So that's where the MRI takes the advantage.
Thank you so much.
And Dr. Tarjani, I would like to say that comparing to the first and second MR in this same section, I'm seeing that even the orbital soft tissue is showing some changes. I'm seeing that the lateral rectus muscle has increased in the diameter as well as the medial rectus muscle, and we have like fuzzy appearance around the medial and lateral part, and also in the lacrimal gland fossa of the right orbit. So I assume it's the component is not just limited to the preseptal and the zygoma, just the tip of the zygomatic bone. It may involve the orbit as well, or imminent, actually, invasion from the lateral part, the orbit. So interestingly, I've seen cases with mucormycosis, not commonly, but I've seen several cases that the zygomaticofacial neurovascular bundle was involved. And the transmission or invasion of the mucor from inside the orbit to the temporal fossa is pretty fast. So in this case, I assume we have kind of disinvolvements because the lateral part of the orbit and the temporal fossa are showing some simultaneous increase in the inflammation and the changes in the signal, assuming that the signal to noise ratio, the third one, would be in the acceptable level.
Right, I agree, Dr. Pakdel. The only other thing there is that once you've given retrobulbar amphotericin B, that itself induces some amount of inflammation, and your muscles tend to look thickened, swollen, and it becomes very difficult to differentiate whether it's inflammation due to ampho B or it's actually worsening of the disease. So what becomes important is to look for necrotic areas. And as long as we don't see necrotic areas there, we sort of tend to assume that the initial reaction in the orbit on radiology is due to the amphotericin B.
I would agree with that. We do the same thing.
Great case, Dr. Tarjani. Thank you very much for sharing that very nice and instructive case with us.
Thank you everyone.
So can you update us for this case, please?
Right, so you're asking me about the final outcome of the patient?
Mm-hmm.
Yes, so this is where you saw the recent scan that I showed you, that's in the middle of this month. So currently he is scheduled for an evaluation with our maxillofacial colleague to figure out what we need to do for the zygoma. The orbit part is quite good right now. He manages to have 20/20 vision even now, and we are not seeing any new necrotic areas. So he is under follow-up, and I definitely get back to the group on what we decide with the zygoma. That's the stage at which he is.
Thank you, Dr. Ajani. Greatly appreciate your wonderful case. Very illustrative, very educative. We can have Dr. Sandeep's presentation as he's getting some emergencies, calls his case, and then maybe he can leave for his call.
Thank you so much, sir. I know, but it's been like I've been bombarded with calls. So I just like to share the case and then maybe. Okay. Now, I have chosen this case, though the patient did well, but there were a lot of I would say residuals, not recurrences. Ultimately, the patient did well, but it posed us a few challenges, us a few lessons. So I took up this case. Like now, Harpal Singh, 58-year-old male, he was admitted with the Department of Oromaxillofacial Surgery on the 18th of November 2020. With the swelling right side of face, 8 days, biopsy showed mucormycosis. Patient was COVID positive by RT-PCR on the 21st of November 2020. And patient was managed in a conservative way by giving injection amphotericin B for the dental department. And an ENT review was sought on the November 30th. And we had planned a surgery for this patient. He had diabetes for a month. He recently diagnosed diabetes and hypertension. On examination, like they referred to us once they found the palatal ulcer present over the anterior palate, and the patient having started swelling in the right half of the maxilla. So that is a preoperative scan for this patient, and not much disease per se, except that there was limited to the maxillary sinus and the palate. So inferior partial maxillectomy was planned, and the patient was operated on December 1st, which showed blackish necrotic tissue in the hard palate maxilla, anterior medial wall with erosion of the posterior wall of the maxilla. So an extended medial maxillectomy with inferior partial maxillectomy was done for this patient. Though the CT scan didn't show much disease. Patient was discharged after a cumulative amphotericin of 1600 milligrams and down referred, where he did complete 4 grams of liposomal amphotericin B. Now, in the 3rd week of February, he presented again with headache, which was slowly progressive over the last 2 weeks. And he had developed ptosis of the right. On examination, the extraocular movements were restricted in the superior and the lateral gaze, but vision was still normal. And this is the MRI, which showed disease in the cavity that time, and some disease in the pterygopalatine fossa. So the patient was taken up for the second surgery, and which showed necrotic lateral and posterior wall of the maxilla. Pterygoids were involved. So again, the anterior posterior ethmoid clearance was done. Sphenoid sinus was opened, secretion and palpebral tissue was present, which was also removed. So this was the second surgery. The first was the inferior partial maxillectomy with some. Now, the headache persisted post-operatively. Neurology call was taken, MRI done, patient put on pregabalin for his pain. The UM restriction progressed. The patient received up to 5 grams of posaconazole. So the salvage surgery had already been completed. There was no intracranial involvement, no other involvement, but clinically the patient was not improving. Patient was shifted to syrup posaconazole, 10 ml twice a day, and followed by 10 ml once a day, and it continued for 3 months. No delayed release tablets were not available at that time, so he had put the patient on posaconazole syrup. Now there was some ptosis still persisting in restricted EOM and headache. Now, after a month again, the patient presented with diminution of vision of the right eye. There was no improvement, not on the ptosis. And there was complete restriction of EOM movements. PL was positive. The CME contrastness MRI of brain and orbit was done, which showed increased and altered signal intensity in right ethmoids and sphenoid with lateral wall erosion extending to the right orbital apex. The endoscopy didn't show any gross disease left. The patient was continued with syrup posaconazole. And after another month of this, the patient, 15 days rather, after 2 weeks, the headache, the doses and restriction of the extraocular movement started improving over time, and by the next, and after 3 months of posaconazole therapy, the cavity was healthy, the movements were full and free, there was no ptosis, vision is but still positive, and no complaints of headache. So this was the brain showing of the orbit and post-resurgery, which was some lesions. This is a healthy cavity after 3 months of posaconazole, full and free extraocular movements, and no ptosis. So the lessons learned why I chose to present this case was that even if the disease is limited at initial presentation, recurrences are common. So we need to counsel the patient, the relatives accordingly, because at the first presentation, it didn't show much disease on a CT MRI. Rhino-Orbital-Cerebral fossa should strictly be part of examination during follow-up examinations and imaging, which I discussed in my first presentation also. The eye symptoms in the absence of gross orbital involvement or involvement of the orbital apex cornea sinus, like the restriction of the movements and the diminution of vision. And we found that long-term posaconazole therapy is effective continuation therapy. Maybe it's just a case report. We need to have more evidence to say that it really helps. But the persistent questions which this patient posed to us, which I would like to ask our esteemed panelists, that what should be the management of disease limited to orbital apex with or without symptoms? And the need for dissection examination of the pterygopalatine fossa, sphenoid sinus surgery during primary surgery, if it is radiologically and clinically uninvolved. Now, we had discussed in the first session also, I think, a bit more about that. And any preventive strategies against indirect optic nerve involvement due to the fungi, maybe fungi embolic phenomenon, in the absence of direct extension of the disease. Thank you.
Dr. Sandip, you're the moderator. You can name one of the colleagues in the panel to start the discussion.
I think if Dr. Reza Vagafi would like to answer a few questions posed, and Dr. Tarjini, and of course Dr. Tabari for the radiological, the dissection part of the pterygopalatine fossa, if there is no radiological involvement. So we have a question for each of our esteemed panelists.
Can you go back to that slide? I'm sorry. I was going to make a comment as far as no radiologic involvement. We have a handful of cases, and I don't know if the group could share if they've seen where there's no orbital involvement. The patient basically, though, presents with blindness, and then you go back and you look at the radiologic studies, and you can just see a small little focus of disease in the sphenoid sinus that's eroding through the canal into the optic nerve. Have people seen such presentation?
Yes. Yes.
So this is the questions. I think, can I stop sharing now?
So the interesting part is when you have limited apical involvement, which is taking up contrast, and then what do you do in that sort of a situation? So when the pandemic began, we were very aggressive in management, and apical involvement was quantified as one that warrants an exenteration. So that is how it began. But over a period of time, we've realized that when the patient receives a good dose of systemic antifungals, and if there is minimal apical involvement, which is taking up contrast, you can let the orbit be and probably not, surgically intervene in that sort of an orbit. However, if there's loss of contrast enhancement at the apex, then the situation completely changes. And that's a situation where you might want to make a decision. If it's a focal loss of contrast enhancement, then between debridement and exenteration, if it's a wide area of loss of contrast enhancement. I'd love to hear the group's inputs on these points.
Dr. Dave, I would agree with your assessment and recommendations. It would be the same for us. When we really look for that transition between where there's enhancing disease in the apex to loss of contrast enhancement. And we would, with enhancing disease and apical involvement, we would treat with retrobulbar amphotericin. But once you lose the contrast enhancement, you know that tissue is ischemic, and then you have to make that difficult decision. The other thing that we have found in a more recent study that we're preparing, actually it's been submitted, is that presentation of apical involvement with loss of vision. That's on that intake MRI. If you see the apical involvement with loss of vision, that's grave visual, that portends for grave visual prognosis. They're unlikely to recover vision despite your best efforts.
I would like to speak about a case that I'm currently seeing. This was a patient who completed his therapy, including debridement. In one eye, that eye is no perception of light, globe has been salvaged. He's received a complete dose of amphotericin B, is on posaconazole. He presented with decreased vision in his left eye, was noted somewhere to have a disc edema, was considered as an optic neuritis in view of, this is a 35-year-old male, and considered as optic neuritis in view of his normal findings on the MRI on the other side, where he developed the optic, so-called optic nerve swelling. And we asked our radiologist to look at it more closely, do a new imaging, and they find evidence of residual sphenoid disease on both the sides. And they still don't say that there is much of inflammation in the orbital apex, but I suspect that this inflammation also has something to do with the sphenoid sinus disease. So a subtle sphenoid sinus disease is also not to be overlooked when talking about the involvement of the nerve.
Sir, I completely agree with you. I've seen a similar sort of a case where the presentation of mucor was with just papillitis. There was disc edema, and on imaging there was perineural involvement. And when you have minimal perineural involvement, it's just taking up contrast. It's very difficult for you to differentiate between mucor and perineuritis from other causes. And then looking at the sinuses very closely becomes extremely sort of important. So we've seen similar cases where the other eye then progressed, the eye with papillitis progressed to have a full-blown intracorneal involvement with mucormycosis. So what was thought of as papillitis earlier actually was mucormycosis. We have seen that as well.
Yeah, so that's important to remember.
So I would like to make a comment and describe my own experiences with apical involvement. So I found actually a couple of different presentations in the isolated apical involvement in mucormycosis. Sometimes it's rapidly progressive with extensive necrosis in the apex. I totally agree. The only thing we can do preventing the intracranial extension is the exentration as soon as possible. But sometimes it's well localized, and if you take another imaging, if you wait for a while by any means, you will see that you are seeing an abscess over there, and it's like a cold abscess. It's like grayish jelly-like foam over there. So I have experience with localized apical debridement endoscopically. And very interesting that recently I have 2 or 3 cases that they started to show decrease in vision like FC, 1 meter FC or like that. So I decided to do localized debridement endoscopically, and the patient improved in vision to 10/10. So it was a great experience for me. So in this case that I'm seeing a localized actually apical collection or necrosis over there, I decided to go over there very soon and debride the tissue, hoping that I can revert the process of necrosis over there. But in terms that we have extensive necrosis over there, like diffuse, actually restricted diffusion over there, I agree, especially when you have lost the vision already.
I had a quick sort of volatile question to ask. So in these situations where you see disc edema and you see certain signs of perineuritis, what would be the group's view on depot steroid in the orbit in such situations? Would anybody ever consider a small depot of steroid, or would it just take the mucor downhill?
I think that the first question is that, what's the reason for this swelling? Is it because of the inflammation or because of the nerve ischemia and slowdown of the exoplasmic flow? I think the second explanation sounds more logic. So in this case, there is no place for a steroid injection, even though steroid injection may further compromise the immunostatus over there and, decrease the cytotoxic activities and macrophage activities and worsen the growth of the fungus. I'm not sure if Dr. Shirzad and Dr. Tabari would like to make any comments about such interesting case.
Thank you very much again. I think it's better for me to say my comments about the second question. Dr. Bansal asked if it's done with the orbital apex. I will say something about that, the tracheopolitan fossa dissection.
Yeah, go ahead, please.
I think for the tracheopolitan fossa and infratemporal fossa dissection, we have to change and reconsider our red flags. For example, many patients will come to us with facial fullness, which may be due to the involvement of the maxillary sinus. But facial paresthesia on the cheek, means that there is involvement of the infraorbital nerve, and maybe, as Dr. Bansal very well covered in his presentation, maybe the beginning of the involvement of the infratemporal fossa. Besides that, in the first imaging, we have to focus on the axial imaging of the infratemporal fossa and PPF, because there might be very, very small asymmetry between those two parts, in order to trying to dissect those parts. We usually do not dissect the PPF and skull base in all patients, but patients who have periorbital edema or any ocular signs, or the facial paresthesia, which may show us that the infratemporal fossa may be involved. So in these cases, I think it's better to reconsider dissection of these parts in order to prevent improving the disease to the CNS, or much more involvement of the orbital symptoms.
Thank you so much.
You're welcome.
Ashok, what's your idea about steroid injection in mucormycosis? Actually, this is a common question asking us, in terms that we have unexplained, inflammation happens. What do you think?
Interestingly, the patient that I was speaking about had a vision, disc edema, but he had a vision of nearly 6 part. The visual field showed a central centrocecal scotoma. He had received 3 doses of IV methylprednisolone, 500, and 2 subsequent 250 milligram ones. And he showed an improvement after them. But he had a recurrence every time, and the symptoms came back. In presence of fungus, I would principally be against the use of any kind of steroids wherever we suspect a fungal pathology. And I would very much think of a local debridement or depend on systemic therapy depending on the nature of the pathology, rather than think of any steroids.
Mohsen, what do you think? I'm not sure if Dr. Kashkul is still connected. That would be great if we can hear his comment, or I'm not sure if Mohsen is still connected.
Yes, Farzad, I'm available here.
Can you please make a comment?
Welcome, Mohsen.
Yeah, great to see you, Ashok, Reza, and
Nice
the other colleagues. It's great to see you all here.
Thank you.
So, to me, I would consider any kind of management for mucormycosis. What we do is based on clinical examination. I do review the imaging. I do review the histopathology just for the help on the side of clinic. The whole management and the whole treatment for me is based on clinical examination. And the first thing comes to my mind when I have a patient who is immunocompromised, especially with a high blood sugar and disturbed or unbalanced arterial blood gas. I would consider mucormycosis starting the treatment even with no imaging, no histopathology, nothing. And we go very, very aggressive in terms of surgery. To me, FES has 4 characteristics. 1, to be performed as soon as possible, to be repeated frequently every other day, be relentlessly debride all the necrotic tissues, and to be associated with amphotericin B irrigation of the sinus, nasal cavity, and the orbit. These are 4 things we share and we discuss with our colleagues on the ENT department when they are going for the FES, to consider these 4. And I would deliver the amphotericin in 3 routes: IV, intraorbital, since of course 2018 we have started intraorbital, as well as irrigation during the fast. Whether the MRI or CT scan is changing, it doesn't affect my treatment management at all. It is a help for me, but it doesn't give me any direction towards what I'm going to do on my patients. I hope I answered the question.
Dr. Shirza, do you want to make any comment for giving methylprednisolone therapy in a case with mucormycosis inside the orbital apex when we have kind of optic nerve dysfunction? So you may educate us from the metabolic side and the perspective of metabolic state. So as Ashok said, we always afraid to give corticosteroids in the fungal infection because we are afraid of the actually after the short honeymoon, we will have a resurge or rebound of that infection over there.
Actually, the use of corticosteroid can rise very progressively blood sugar, and the best way for controlling the blood glucose is IV insulin infusion. And when patient is in the ICU or in the ward in the department of endocrine side, for example, the best way is IV insulin infusion.
So what about the whole idea of injection of the corticosteroids?
I don't idea about this this method. I don't any information about that, but actually this has effect on blood glucose.
Okay, Dr. Tarjan, do you want to update us for the fate, or maybe Dr. Bansal? Sorry.
I would not consider a steroid injection in case of mucormycosis or any invasive fungal disease. Like I would not like to risk aggravating the disease or increasing the inflammatory pathology, or maybe a fungemia leading to a fungemia or a fungal angioinvasion. So I would not like to do a steroid injection.
I would agree with that. What we say is you're feeding the fungus sugar.
And as Dr. Shirzad educated us with iron and sugar, because when you raise the blood glucose, you're releasing more iron, so you're offering the fungus more food to reach and propagate. So thank you very much for the great case. And actually, we have another presentation, but Dr. Khodavesi is just 1 or 2 minute presentation from the new techniques for rapid detection of the mucormycosis. Dr. Khodavesi, are you connected with us?
Hear me?
Yeah.
You hear me? Okay.
Yeah.
Thank you for your nice meeting in this webinar. I used several things about clinical, but unfortunately, as Mohsen mentioned in his comment, in the presented case, doesn't use the laboratory, the medical or microbiological or mycological laboratory for the confirm the diagnosis. Unfortunately, this is important for the confirmation of diagnosis, but it needs to use of this matter. Like other invasive fungal infection, diagnosis of mucormycosis is challenging. As you know, early and accurate diagnosis is important for improved outcome of mucormycosis, given the limited therapeutic option available. Therefore, we should be use of the mycological laboratory for confirmation of diagnosis. Let me to present some slides for understanding the mucormycosis diagnosis procedure. If possible, I want to share the screen. For laboratory diagnosis of mucormycosis, we use of two type of method: conventional method or non-culture based method. In the conventional method, we use of direct examination with cowhide, wet wound, or calcofluor or blancophore. And also in histopathological examination, we use of PAS and GMS stains. And in culture, we can receive result for isolation of fungus, and also fungus identification. Culture enable us for antifungal susceptibility testing also. In group of non-culture based or neo-based methods, we use of molecular method and immunological methods. But unfortunately, in conventional method, we have several limitations. In conventional method, we need to tissue biopsy or aspiration with cannot be timely achieved in the patient with thrombocytopenia, and this is very difficult for some of patients. And also, these methods take a long time to establish the diagnosis. And some of this method need to expert person, technician person in laboratory. And it is important to note that even in positive microscopy or histopathological examination, 15% of cases have a culture negative, and this is very important for the notice. Because the visuality of the fungus may have an impact on the sensitivity of the diagnosis method, look like culture. And also some of emerging mucorales species such as Apophizomyces elegans and Saxena vasiformis fail to sporulation on routine method. Please look at this picture. In upper picture here, we have Mucorales hypha. Mucorales hypha are aseptate or scarcely septated and fragile, and also ribbon-like in compare with the Aspergillus hypha or other septate hypha, as you see in here. When we expose with this picture in the direct examination, it's very confusing for the diagnosis, and it needs to the other method for the interpretation of the examination test. In other hand, we don't have any serological method for diagnosis of mucormycosis. We don't have serological tests for also look like beta-diglycan galactomannan assay for mucormycosis, and as to this limitation, it is better to use of the molecular assay for diagnosis. Today, newer molecular methods are evolving quickly and display great potential in early and accurate diagnosis of mucormycosis. We use of the several type technique of molecular assay like conventional PCR, PCR-RFLP, real-time PCR, sequencing, probe-based PCR, HRM assay, and with the use of this technique, we can detect and identification of the etiological agent of mucorales. I want to say about DNA extraction. For all of this technique, we need to the pure and good amount of DNA. If we send the sample with in the formalin to laboratory, unfortunately, formalin can be adverse effect of DNA extraction or DNA amount. It is better to send to sample to the laboratory in the normal saline for all of tests, especially in the culture and the molecular test. Between molecular tests, today HRM tests or high resolution MELT analysis is very good for diagnosis of mucormycosis because this technique is simple and enable rapid and non-expensive for the detection and identification. Because this technique, as you see in the below table, in compare with the histopathological result and culture result, you can see that this technique can be reliable result and also identification the etiological agent and able to distinguish the main clinically mucorales, and some of the reported result about HRM shows no cross reactivity with another filamentous fungi like Aspergillus. I recommend my clinician colleague to believe to the mycological or microbiological laboratory for confirmation of diagnosis, because as I say in this presentation, if we decided with just direct examination or histopathological examination, maybe our diagnosis will fail, and it needs to the other more work, look like molecular techniques on the specimen for the reliable results. However, unfortunately, molecular methods are currently limited to add-on analysis to culture and microscopy, especially in development country, look like Iran. I hope this presentation is benefit to my clinician colleague, and if you have questions, I'm here to answer to you.
Thank you very much, Dr. Khodaveisi, for the nice presentation and updating us for the new technologies for rapid diagnosis of the mucormycosis. So it was a really deep inside the mucormycosis, and we tried to review different aspects from different perspectives, different disciplines into the problem. That was great to have such a actually group of stars and such a nice audience here. So I would like Dr. Bansal and Dr. Ashok to give us the final words and close the meeting.
Thank you, Prasad. I think what is important for us to realize is why we've had so many more cases in our countries than in some other parts of the world. As I said, maybe tropical climate has something to do with it, but predominant reason has been a poor control of hyperglycemia, and compounded, of course, by the COVID itself, which has brought about fresh cases of hyperglycemia and the other changes that COVID has produced and the steroids that have been used concomitantly. So I think and this situation of poor control of hyperglycemia gets aggravated in a condition where the hospitals are overpressurized, a lot of domiciliary treatment is taking place, many patients are not able to get admitted into the hospital, and there is such an overload on the clinicians. I think a much greater attention to hyperglycemia and the immune status would be critical to preventing more such episodes if we get any further waves. I think that is the one most important aspect that I would like to stress. Of course, we saw the impact of public education, that although the public education on mucormycosis did result in some panic around the country, but the result was that many patients started presenting at the stage where they only had rhinological involvement. And the numbers of those who presented with vision loss or with orbital involvement decreased considerably in the latter part of the pandemic, of the second wave. So I think education, public education is critical. Understanding of what is causing it is important for us to make sure that other parts of the world are spared from this and that we are able to treat them at an early stage. Thank you for a wonderful, wonderful program. It has been very educative. All perspectives were covered well, and the discussion was really very, very nice. Thank you, Fazal.
Thank you, Ashok. Dr. Bansal?
He may have had to leave. I think he was,
Okay.
yeah, because he was getting a lot of frantic calls.
So I would like to thank all of the speakers and the panelists and dear colleagues that stayed with us until late now. And we may say goodbye and ask them have a nice evening.
Thank you. And wonderful faculty. We must thank all of them for the really wonderful educative talks.
Thank you. Bye, everybody.
Bye-bye.